screen. Hang on, I'll just, because I need to share my audio for my PowerPoint videos to play. So let me just turn on the settings for my audio first.
Since you are on mute, I cannot hear you. Hello, Sinchi. Sinchi, you are on mute. Hello, Sinchi, can you hear me? Sinchi? Sinchi?
Sinchi, can you hear me?
Sinchi, hello?
Hello, Sinchi.
Okay, okay. So let's text her. Apology for an inconvenience, so we will reach out Sinchi soon.
Sinchi, can you hear me? You are mute. Can you hear me, Sinchi? I can hear you ค่ะพี่ปันเดี๋ยวแจ้งซินฉีไปแล้วค่ะเขากำลังแก้อยู่ค่ะพี่ปัน Sinchi, can you hear me? But I can't hear you.
Sinchi, you may need to reconnect it.
Maybe you will you must reconnect again, Sinchi.
Okay. Hang on.
Okay. I can hear you now. เดี๋ยวรอแป๊บนึงนะคะ
Hello, can you hear me now?
Yes.
Yes, I can hear you.
Oh, okay. Let me try again. I think because when I try to connect my computer to allow the listening. Hang on. Let me try again. Hello, can you hear?
Yes, I can hear you.
Okay, I guess I cannot share my computer audio, so later during any kind of videos, I will do manual voiceover. But okay, let me start. Sorry for that. Let me start from the very beginning again. Yep. So just now I was introducing myself. I hope you can hear me now. But yeah, I was saying I'm very pleased to be here today for this guest lecture session. I've been a clinical and product trainer for the Asia Pacific region at Teramo for the past 4 years. And my team specifically run education programs relating to interventional cardiology for coronary artery disease or CAD for both internal associates and also healthcare professionals. So I believe later in February, you have an opportunity to experience an important part of our education program, which is simulation based, which is really more exciting than just having lecture like that, because you'll be able to touch and feel how devices feel and are used on vessel models. But today, let me first introduce the theory, how procedures are done and devices are used in the interventional diagnosis and treatment for CAD. I will show you as much as possible what happens in the CAD lab so that you can understand where and how the devices are used throughout the procedures. Just one thing to note, when I name people and places and items, it may differ even in different CAD labs in Thailand. So I will introduce most of the terms, but it is more important for you to know the concepts and you'll be able to eventually pick up the correct names in the field. Okay, so take note of the disclaimer here. Oops. Yeah, so unfortunately, I cannot join you, physically because of the COVID situation. So to make this session more interactive, I'd like you to participate on Slido. So you see a QR code here. You can scan this QR code or go to the link slido.com and key in the meeting code 138101. If you scan the QR code, you'll be asked to enter the passcode, which is W4QSSN. So if you manage to get into it, you'll be able to see this poll. So I will be, throughout the session, I'll be throwing questions so that you'll be able to follow and know what's coming up next. So during these poll questions, don't worry, there's actually right and wrong answers, but don't worry about getting it right or wrong. It's going to be, anonymous. I just want you to think and see, in your opinion, what is right, what is wrong, and we will learn throughout the lecture itself. So just, get onto the Slido. There's this Q&A button also. So if you have any questions, you can actually enter it here. Otherwise, you can voice out too, but it may be quite disruptive because of the audio things. But if you're okay, you can actually enter the Q&As here, and throughout the session, I will be checking in to see whether you have any questions for me to address. So yeah, I can see people joining in the polls now. We have 12 of us answering. So I guess most of us have no problems in the answering the questions. But yeah, so I see everyone is quite happy, like the bulldog, mostly, yeah. So I'm glad to see all of you, although this is remote. But let's try to have this, lecture to be really productive and learning. Okay, so let's get started. Oh, this is the wrong presentation. this is the right one. Okay, so I'm going to start with what is interventional cardiology, because you'll realize that interventional cardiology means a lot of things in your cath lab. It covers a very large scope. So it includes many heart disease on top of the disease that is relating to coronary arteries. So in this table, you see this is an example from the North Shore Private Hospital IC department in Sydney, Australia. They provide this list of service. Some common ones that you will see is like the EP service, pacemaker, and also like TAVI. So I think some of this you'll be able to learn throughout the your journey in your course. But what we would like to focus today is relating to coronary artery disease, which is relating to angiogram, or also known as CAG, coronary angiogram, and also angioplasty and stenting, which we always term it as PCI, percutaneous coronary intervention. So this is our focus for this session. We will be looking at interventional cardiology for CAD, specifically for CAG and PCI. So our focus in this first half of the IC for CAD is the procedure itself. We'll first talk in very general terms, then we'll specifically go into CAG and then PCI. So in very general procedure terms, it's important to note that there's these standard things that nurses will check. So whether it's a correct patient, whether they have the correct file containing the patient records, etc. So these are, I think, very standard things. You probably will be looking at this eventually. One thing that is the most foreign to you is probably this INR, the International Normalized Ratio. This refers to the time taken for blood to clot, right? So certain patients will need to take anticoagulant medications to extend blood clotting time because they have some conditions. But this is very important because for a doctor, because this condition, or if this ratio is abnormal, it may increase the bleeding risk during the procedure. So no matter what, they will always have to take a look at this. We'll also come back to this INR a bit later. But one thing about anticoagulant is that, this is actually required during the procedure because devices will be inserted into the vessel. So we do not want the blood to start clotting around our devices or in the vessel too quickly. So generally, patients will be given something called the UFH, the unfractionated heparin. And doctors will use what is called the activated clotting time to measure and maintain this effect. Okay, so there are other methods like the LMWH, which is more commonly used recently because the effect is more stable. Because it is more stable, they then don't need to use this ACT to actually continuously track the level to maintain it. Okay, so yeah, video wise, I don't think you can hear the audio, but I'll just voice over as much as I can. But before this, I'm gonna show you this video. It's done by the Horizon Health Network. It's a healthcare organization in Canada. It's meant to prepare patients mentally before the procedure, so it's quite useful for you to see their general flow. I will stop the videos in between to highlight certain points that will be good for you. But let's try whether, I don't think you can hear the audio, so I'll just voice over. Okay, so I think no audio. So before the procedure, what happens is the doctor will prepare the patient in the ward itself. So this is not in the cath lab yet. This is in the ward. So they will basically hook them up and normally shave the area so that they can actually prepare this site for access. It can be at the wrist, just now as you saw, or at the groin. So they will wrap some antiseptic so you feel cool, basically for the insertion before they actually move the patient into this cath lab. So you can see that there's actually, this is what you will see in actual, in the cath lab. Basically the nurses will be preparing the patient for this procedure in not the cath lab, but in the ward, and then they move into a cath lab. So what is important to note is that there's these different rooms that you need to pay attention to. There's this patient ward, it's also called the day surgery unit. It's where the patient gets prepared for the procedure, and also after the procedure, they will return to this place, the patient ward, to recover. The procedure is done in a cath lab, a catheterization lab, and this is where the patient will undergo a CAG or PCI. Okay, this is in the cath lab. So once the patient is moving, they'll be moved onto this table. So it's no longer called a bed. It's simply a flat piece of table. And the doctors will then start preparing for this procedure. You will see this monitors that monitors the vital signs of the patient to check, how well the patient is doing. Again, they will clean the puncture site. This is the arm again, your radial puncture. So they will also spread this sterile sheets over the patient. So these places are very sterile, which means they are very clean. We need to maintain this sterility to ensure that there is no contamination and no inflammation, the patient won't be in trouble just because of sterility issue. So the whole place here is sterile. Your arm is sterile. They will actually rub with alcohol to make sure that everything is sterile. And as you see, the doctors, the healthcare professionals will be scrubbing down, will be wearing the correct attire for this procedure. So the cath lab is where the procedure is performed, and it's probably where you will likely be supporting your doctor as required. So in the cath lab, the largest device is this X-ray machine. It's called the C-arm because of its shape, right? There'll be always this shield. Here it's a bit hard to see, but it's normally a transparent shield that is next to this C-arm, and it acts as a barrier to reduce the radiation from the C-arm to the doctor. The patient will lie on this table, and most likely there's this trolley that is going to be nearby. There'll be monitors that will be showing the patient statistics like the heart rate, blood pressure, angiogram images, etc. And these monitors are typically monitored or controlled remotely. It's usually controlled in this control room, which is actually separated with a glass window from the cath lab. So this separation actually prevents the unnecessary radiation risk outside the core team. So the core team is the doctors and support staff within the cath lab. There's this X-ray machine in there, right? So that the radiation level is so high. So to reduce the unnecessary risk, the people who needs to control the monitors doesn't have to be in the room. So they'll be in this control room to help with this monitor display. Whereas for medical devices, they are typically kept in the cath lab, but if there's space constraints, you can also find them in the control room. So for the cath lab team, you will see the first operator, which is usually the lead interventional cardiologist performing the procedure. And beside this first operator, there's this second operator who could be an interventional cardiologist, or it could also be a scrub nurse. So this second operator might not be a doctor, he could be a scrub nurse also. This person is basically the assistant for the procedure. So this person will always stay by the side of the first operator. There's also going to be one or more circulating nurse. This nurse will basically support the team by looking for the devices that the operators ask for, and also takes care of the patient, like to calm the patient or to provide additional blankets. So in the cath lab, we also have radiographer, because regardless whether it is a CAG or a PCI procedure, you'll always have to take images, basically your angiograms. So this radiographer is the cameraman and take images throughout the procedures. In the control room, typically we have the other members such as the technicians and other nurses to support the whole procedure. And usually these people take notes of the entire procedure, like, take down what kind of devices are used, help to actually control the displays, etc. Okay, so I have a first question here. So if you look at your Slido on your phone, so I know that you probably see, even if you haven't been to a cath lab, you probably see these image in movies and stuff. So if you observe the attire of this team in the cath lab, within, where the cath lab is now, not the control room, but in the cath lab, do you think this team is wearing appropriate attire? Is it enough for sterility? Is it enough for cleanliness to make sure that the patient is in a very good condition? Do you think it's a yes or a no? Are they wearing correct attire? So you can, as you participated just now, just enter your answers. Oh, how come I don't see it moving? Okay, now I see it moving. So we have half, exactly half almost. So half of you are thinking that, yeah, they look like they're wearing the right attire, but some of you think that they are not wearing the right attire. Okay, so we have almost exactly half us. So I'm gonna move on and let's see. You'll be able to find the answers here. Okay, so basically there are many things to put on in the cath lab. So from this image, you probably see the difference. I hope you spot the difference between this and the previous image. So on this image on the right, this is actually the most basic attire. So what you will have is the cap, a mask, and your shoe cover. Let me just minimize it. So your cap, your mask, and your shoe cover. So these are the most basic things that you will put on. This cap, usually what you will wear as a support staff is disposables. But if you are a regular at a lab, you will have something that is reusable. Typically, these shoe covers, masks, and caps are all disposable. This will ensure cleanliness and reduce the infection for both the patient and the medical staff. So you're not just protecting the patient, but you're protecting yourself and the people around you generally. So it's very important to wear this attire. Typically, you'll be also in scrubs, and whether you'll be in lab apron, this one, it depends on whether you need to support your doctor in the cath lab. So as I mentioned, there's actually radiation in the cath lab. So this apron is very important attire when you are in it because it's made of lead. So it actually reduces the radiation that is going to penetrate the core parts of your body. So typically when you wear this apron, you will wear it at your neck and your body, and especially at your heart. So it protects this core area so that the radiation to these parts will be minimized. So in the control room, typically you won't be requested to wear this lead apron since you are separated with the glass window and there's some distance already. But typically, just in case you have to be in the cath lab, they will request for you to be actually in the lead apron. Okay, so in the cath lab, you definitely have the lead apron. And for the operators, they actually have additional things. So things that you don't see just now, like the protective eyewear, gown, and gloves. So the operator is in direct contact with the patient, and they have to be really sterile and they have to be really clean to ensure the patient safety. So basically, you can treat the operator as being very sterile. So one thing to note is that, for this operator and the first operator and second operator, we typically don't pass them anything. Like, you have devices in boxes. We typically don't pass them at all. You have to take note of this when you're in a cath lab. Do not touch them. They are basically, their attire is for sterility and everything. So you need to not touch them. Let the scrub nurse or second operator handle everything. When you throw devices later, I will let you know. Basically, even the plastic package that you have within the box is actually not sterile. Only the devices within are sterile. So typically they will have to open the plastic and drop the devices on the sterile area around the nurse, maybe on the trolley also. But definitely you don't pass the plastic or the box to these operators because they really have to maintain a very, very high level of cleanliness and sterility. Another thing that they may wear, actually they will wear, is this device called the dosimeter. So this dosimeter is something that records the amount of radiation, because operators and scrubbers are standing very, very close to this, right? This actually give out radiation. They are standing so close to it. To ensure the doctors and the healthcare professional safety, they will actually wear this to track their levels, so that to ensure that they are not getting too high dosage of the radiation. Okay. So as I've mentioned, these sheets are actually sterile. So they are laid over the patient. So these surfaces are all sterile. The operator, you see they're wearing gloves and they're wearing their gowns. Everything is sterile. So again, we need to take note to not even touch, right? When we pass by, we don't just touch the surface, because typically we don't wear gloves. It depends. It depends. But then typically we are always handling things like pens and things that are not sterile from outside the lab or stuff. So we don't touch surfaces on the patient's table, and we don't touch the operator either. We don't pass them things either. Okay. So let's move on to the video. So here they will inject a, what is it called? They will inject the, not painkillers, the anesthesia, the local anesthesia at the puncture site, typically, and then use a needle to puncture a hole within the access site. So this is at the arm, the radial. They'll put this mini guide wire in and remove the puncture needle to put in something called, as you see on the left of the image, a sheath. So this is the very, very first step of the procedure. But before I'm going to go into the sheath step. So puncture needle is actually the very, very first step. But that's not considered the actual device lah. Needle is just a needle, right? It's like any kind of puncture needles that you use. Actually, when we say the start of the procedure is typically when you insert the introducer. So before that, I would like to highlight that devices have to be prepared before they are inserted into the patient's body. Needles, not so much, but as I mentioned, the devices that I refer to starts from the introducer. So why do we need to prepare this device? Because these devices may actually cause blood clotting. You know how when you have a wound, there's typically clotting that happens immediately. And if there's foreign items in your body, same thing. They will actually, your body will react to this foreign item and cause clotting. And another reason why, so other than this clotting issue, is that you always insert tubes and sheaths. Later we'll cover what is that, the tubes and sheaths into the body. So if this is the body, you have to put this in. You realize that there's actually dead space within here. Dead space meaning that there's air in, like straw, right? In a straw that you drink your drinks from. There's actually dead space inside. If you just insert this into the body, what happens is there's air inside, you put something through, there's going to be bubbles, air bubbles that is going into your body, and not just your body, it's going into your blood, right? So if it's definitely not good news to have air bubbles in your blood, because this will act as like a blockage. So it may cause your vessel blockage when you introduce devices like that directly into the body. So of course, one thing is you don't want blood to start clotting on the surface. you also, if there's actually space within the device, you don't want to actually push air bubbles into your vessel. So how they actually prepare the device is to flush it with saline with added heparin. So what heparin does is that it reduces the risk of blood clotting. So with these two solution, the saline and the heparin, it will have two effects. It will first reduce the risk of blood clotting in or on the surface, and secondly, because you flush the insides of the devices with liquid, right, with your saline, basically then there will not be air bubbles basically introduced into the blood vessels. Okay, so let's take a look at this video. So just now we saw the procedure from the puncture needle. So they put a puncture needle in. Let's assume that they have started they have placed other devices in. They have placed this catheter, this long catheter in, and let's see what's going to happen. So what's going to happen after they place this long catheter? You see the blue line? It's actually your contrast media. So with this contrast media, you'll be able to take images of the blood vessel. So once you take the images, then you'll be able to analyze whether there's anything that is wrong with the vessel by looking at how smooth this vessel is. So if it's not smooth, if you see like this vessel, actually this may have something wrong. So you can see that this is quite thick, but then it went down to being slightly thinner. So in our vessels, definitely it will taper, but it shouldn't taper and then become bigger again. So if this happens, it means that there may be something wrong in the middle. There may be some congestion and some lesion, some blockage in that area, which needs to be treated. So here, I haven't gone into the procedure. I just want to introduce it in general. I want to let you know what is a contrast media. So a contrast media is what you saw just now that is injected into a catheter. So it's usually iodine based, and it can be injected through the device, basically take pictures of the coronary arteries. So creatinine is a word that we saw earlier during patient preparation. So doctors need to actually pay attention to this because high creatinine level means that the kidney actually fails to remove this from the blood, right? So if your kidney is functioning very poorly, indicated by very high level of creatinine level in the blood, the body will not be able to safely clear the contrast media, and it will cause the poisoning of the kidney, a condition that is called a contrast nephropathy. So one thing to note is just now you saw the patient preparation. They will need to see whether the patient has very high level of this creatinine. If they have, maybe they shouldn't use this contrast media. They have other alternatives other than iodine-based ones that they can use, but it's not as effective. The most common one is still iodine. Okay, so so basically you can see the C-arm moving. The C-arm is where the X-ray is coming from. So when the contrast media is injected through, this C-arm will basically be going around your body. It will not touch the patient's body, but it will go around it to take the coronary artery images at different angles. So some let me highlight one point here. So you saw how this operator here, he basically moves this shield. Just now I mentioned you cannot really see, but he moves this shield between himself here and the C-arm. So it's very important to do that. And for you, if you are supporting in a cath lab, you will never stand in this point. You will never stand on the left side of the shield, which is next to the C-arm. You will always stand on the right side here, so that you will be as far away from the C-arm as much as possible to protect yourself. Okay, so I've mentioned, I keep mentioning C-arm, so I'm not so sure whether you know about this, but let me just very, very briefly go through. The X-ray or the C-arm machine basically has its X-ray tube at the bottom. So this is where the radiation source is from, and the top tube here is the image intensifier or the camera. So X-ray can pass through soft tissues like blood vessels, but contrast media blocks this X-ray from going to the camera, right? So you will see a shadow, and that's how an angiogram is created. So just now I've mentioned a lot of times that radiation is very harmful, and you know how you can actually minimize the radiation dose or exposure in the cath lab. So I keep mentioning that it's dangerous. I don't know whether you know why, because this increases cancer and also other health risks. And although it increases all this health risk, there's no medical staff has no choice because they have to actually treat the patients, and the patients need this X-ray to be able to see, you know, what's happening in the cath lab. So to maintain their health, what strategies can be used to actually reduce this radiation exposure? So I can tell you that there are 3 answers. These 3 answers are actually very, very commonly used in the cath lab. I think if you go into any cath lab or even an X-ray room, even an X-ray observation room, they will always tell you to do this. From your observation, when you do your health checkups, you will experience this. So how can you actually, there are actually 3 right answers, which I think actually most of you got it. Um, so actually you're right. So you don't, the X-ray power saving mode, I don't think there's actually such mode. I just type in an answer just to you know, to imitate a phone with a power saving mode. We actually don't do that. The 3 main things that you can do to reduce radiation exposure is definitely, as I mentioned, use shielding. Shielding doesn't mean just the transparent shield that, you know, is in between the doctor and the C-arm. Shielding includes your apron. So whenever you're wearing an apron, the LED devices, this is a shield between the radiation and yourself. Limit time, definitely. If you don't have to be in the cath lab, you don't have to be in there, right? So limiting time definitely will reduce radiation exposure, and increasing distance. So the first operator has no choice. The first operator stands closest to the C-arm. But as a support staff, you don't actually have to do that, and you are not recommended to do that. And that's why you may not also carry a dosimeter. For healthcare medical staff that needs to be very close to C-arm, they will always wear this dosimeter, the device that tracks the amount of radiation exposure you have. But typically we don't wear it because our distance is not so close. Our time is also exposed to this radiation is also not so much. So these 3 are actually the strategies that you will definitely hear in the cath lab to reduce radiation exposure. Okay, so just now you saw the C-arm moving. It can rotate sideways to the left or to the right of the patient's body to capture the heart from different views. So if the camera is on the right side, on the right side here of the patient's body, this is the right anterior oblique RAO view. And if it's on the left side of the body here, it will be the LAO, or the left anterior oblique view. So the maximum that the C-arm can rotate sideways is at 90 degrees. So you can see RAO 30 like that, 40 degrees like that, and up to 90 degrees here. Okay, then other than sideways, the C-arm can also rotate its camera to the feet of the patient. If it's at the feet, so the feet is here, right? The feet is here, so this will be considered a caudal view, and it can move to towards the head, which is the cranial view. So typically, there's a limit to how much you can rotate this way. They don't do it up to 90 degrees. Usually the maximum is up to 40 degrees, like 30, 40 degrees, because if you do 90 degrees, it will hit the patient's head lah, and you don't need to have such a steep angle. So typically they do 30 to 40 degrees rotation. And for the more accurate representative of coronary arteries, more than one angle is typically used. So to view the left coronary artery, actually this left coronary artery is more complex than the right. There's actually a lot of views that needs to be taken because we have to view the complex arteries in different angles to very accurately say where the problem lies. For the right coronary artery, this is more simpler. So there's only 3 views typically that they use for the angiographic framing. So in the cath lab, so when they start the procedure, not they start the procedure, after they manipulate the C-arm, they will inject the let me see. Yeah, basically what they're saying is they will actually discuss with the patient. The patient is actually not put to sleep. They are not actually put under general anesthesia. It's only local anesthesia. The patient is awake. Typically, the doctor will discuss with the patient, the condition of their coronary arteries. This is especially so for cases which are not so serious. If you have a serious emergency case and heart attack, then you will probably not have so much discussion time. But this is probably, every few weeks I have some heart pain. Then it's some minor blockage. So in this case, the doctor and the patient will typically discuss and confirm whether they want to actually proceed with the procedure, with the treatment procedure. So treatment doesn't immediately come with the diagnosis. This can be a totally separate treatment. So one thing to note about angiography is that there is actually 2 modes for this to take the images. The first is called the Fluoro, and it refers to the low continuous X-ray exposure. And because it's low continuous X-ray exposure, the images actually have very low quality. But it's enough for like catheter advancement. So typically this is what they use. But when they want to take images of higher quality, when they want to take an angiogram, they will call for Cine. And this takes a snapshot of very high quality image. And this uses a very intense, relatively more intense pulsed X-ray exposure. Okay, so next question. So just now I mentioned Cine mode gives a higher quality image. So if it's higher quality, then isn't it better to keep using it? Why don't they use it? Why do they still use fluoro for like catheter advancement? So I have 4 options here, whether it's to reduce cost, to reduce work like manpower, reduce radiation, or reduce device wear and tear. So in the image here, you can see this is on the left is the fluoro setting, and on the right is Cine. So Cine, you can see definitely more details, darker images. So it adds some value to the doctor, but they don't use Cine very commonly actually. The more common ones is actually fluoro angio. So yeah, I think everyone got it right. So this the intention of using a fluoro generally is basically to reduce radiation. You know that with higher quality image, it takes a higher pulse X-ray. That means you need to actually use a higher power of the X-ray to actually produce the image. So to be able to do this, we just need it for angiogram, right? Angiogram is to check, how the condition of your coronary arteries are. So we need a very high quality image to do that. But generally, if you just want to check where your devices are going up into the body, etc., you don't need such high quality. So we don't want to expose the patient. The patient don't have, you realize the patient do not have any shielding, right? The whole time they are in there, they don't have any shielding. They are going to be exposed to this radiation. We want to minimize this. So for the patient's sake, for the medical staff's sake, we will typically use fluoro instead of continuous Cine angiography mode. Okay, so as generally what you will see for CAG versus PCI. So CAG is the diagnosis part. CAG typically takes half an hour to 1 hour. And most of these diagnostic procedures are typically the same day discharge, which means that it's a day procedure. The patient is discharged the same day when he is admitted. So a PCI procedure takes about an hour, or it can go up to 2 or 3 hours if it's very, very complex. Treatment procedures are associated with higher risk. So typically patients stay the night for HCPs or for the doctors to observe their condition and ensure their safety before they get discharged. But in recent years, actually, a lot of times you will see that because the treatment procedures are getting more safe, so there's increasing interest in actually same day discharge. So especially COVID, right? You don't want the patients to take up the bed for too long. So this same day discharge is getting trend is getting more even for PCI, for treatment procedures. So now I'm gonna show you the last step, last very general step of the procedure. You saw from the puncture up to from even before that, from the patient ward preparation up to the cath lab preparation. They puncture the needle, put in some devices, put in some contrast, check the conditions, discuss whether the patient needs to actually proceed with treatment. So after the procedure, what happens is you need to remove the sheaths, right? You need to remove the device from the access site. So there are, as you can, if you can remember, there's two access site. One is your arm and one is your leg or your groin. So let's first look at the sheath removal after radial access. So typically sheath removal after a radial access is done in the cath lab. You can see the doctor putting a band around the patient's arm and basically compress it. This is like a watch, right? So basically compress it and then make sure that no bleeding is happening, and then basically you can be moved back into your recovery room, your patient ward. Okay, so that's sheath removal after radial access. So let's take a look at sheath removal procedure after femoral access. Femoral is basically the artery, is describing your artery that is in your groin. So femoral access wise, typically is not done in the cath lab. They will move them into a recovery room. So in this recovery room, basically, again, they will set, to basically track the patient's vitals, right? They will always attach devices to do that. And then they will actually remove the sheath from the patient's femoral artery. And how they actually stop bleeding is to manually compress it. And the patient typically cannot move because it's on your leg, right? So if you actually sit up and start moving around, what happens is that bleeding will happen because typically at femoral puncture, the puncture site is bigger compared to your wrist. So bleeding actually happens quite easily. And so the patient is actually requiring bed rest before he can move into. So he's going to stay in this recovery room for a few hours before he can move back to the ward itself. So just now, these two video clips, it demonstrates the sheath removal step with radial and femoral access. So what do you see is the key difference between these two procedures? Is one more complex than another? Is the closure method different? How mobile is the patient? Can the patient move after the procedure? Or is the manpower of the medical staff very different? So we see a lot of us observing that patient mobility is very different for these two procedures, which is, I think, you guys pay attention to me. So basically, as I mentioned, for femoral access, when you actually when the doctor actually assess the puncture, assess the heart through your groin, through the femoral artery, the patient cannot move very much very soon right after the procedure, as compared to your arm. Your arm is just, you can walk, right? You can still walk to the toilet even though your arm is, needs the bandage. It doesn't matter. But if it's on your leg, on your groin, you cannot stand up and move after the procedure, very, very quickly after the procedure. So that's the greatest difference between the femoral and radial access. Closure method is actually also very different because there are different parts of your body. So for your radial, basically a band or bandage, it will work. But for your femoral artery, it will not. What happens for femoral access is that medical staff, including technicians, including nurses, it depends on rotation, depends on who is available in the hospital procedure. Someone will be there and doing manual compression. So they will basically compress with your hands and your arm and your body weight, basically press down on the access site for a couple of hours until it stops bleeding. So this is the greatest difference between femoral and radial access. Complexity level, okay, there's some difference, but actually not very huge between radial and femoral. Generally, complexity is quite similar, especially because for femoral access, it is the traditional access site. Typically, they don't use the hand because they think that the hand, your artery is smaller, so it's more difficult to go through. So they typically use your leg artery because it's bigger. So, you can put a lot of devices in, more devices in for the procedure. Manpower, yeah, definitely a bit slightly different, especially if you have to do manual compression. But actually, recently there is devices that has, for our femoral artery, there's actually closure method that does not require manual compression. So not so much. The greatest difference is really the mobility of the patient and the closure method. Okay, so as I've mentioned, other than the two rooms, the patient ward and the catheterization lab, there's actually this additional room, the recovery ward. In the video, you saw that the femoral sheath is not removed in the cath lab or in the patient ward, but in this room. So this is where the patient will be initially observed until they are stabilized, and then they will be moved into their day surgery unit or their patient ward. Okay. So at the end of the procedure, basically move back to your patient ward. And again, check for your vitals, check for stability. I think from here, it's quite straightforward. So that's the patient's journey. So for patients wise, that's what they will experience. They will go to basically their wards, get prepared, go into a cath lab, get a contrast media in, with the devices. And depending on the closure method, remove the devices, close the puncture, and move back. Go to the recovery ward to check their condition, and then back to the patient ward. Typically, this is the procedure of the patient. So if I see this slide, that means there's no questions. So if you have any comments, you can also leave some comment on the Q&A part of your Slido. But yeah, if there's nothing, I will actually go on. Yeah, basically what I have still for you is the CAG procedure and the PCR procedure. I will start with the CAG procedure. So I think in the general procedure, you have seen this a little. And what I refer to as CAG is basically the short form for coronary angiogram, also known as angiogram or angio, or sometimes they call it as diagnosis. So you saw in the general procedure that the first step of the IC procedure is to gain access. And the most traditional way to do it is through the femoral artery at the groin. So this is your leg artery, and this is the optimal puncture site. It's actually only 3 to 5 cm in length, where you can very ideally puncture it, but it's quite easy to find. Basically, the doctors will actually know how to find it. Basically, if there's a bone here, it's usually right in the middle, as you can see here. So that's the optimal puncture site of the femoral artery. And this procedure is called TFI, so transfemoral intervention. And access site at the arm is called the transradial intervention, so TRI. So this is an alternate access site which is gaining a lot of popularity recently because, as you saw, the patient can move around much quicker after the procedure. So there are two arteries on the arm, the radial artery and ulnar artery. So radial artery is more on the outside of your arm, and ulnar is towards your body. So typically we use the radial artery, but ulnar artery can be used also, although it's not the very preferred option. In the field, you may also see doctors puncturing at here, basically the distal radial. So not just here at the radial artery, but they go more distally because they think that, you know, the more distal that you go, the less damage they cause to your body. Radial artery, if let's say something happens here, it's still good because you still have your ulnar artery that can provide blood to your hand, right? But it's not so good because it reduces the amount of blood that can go to your hand. But if you go as distal as you can, the damage caused, if any, will be much minimized. So typically they use radial because they have ulnar as a backup for blood supply to your hand. But recently they are trying to move even further down to improve the patient's satisfaction. So you saw that there's TRI and TFI, transfemoral, transradial. So in terms of device properties, what do you expect to be the same? Will the size of the device used for TFI and TRI be the same? The length be the same? The stiffness be the same? Or all of them different because it's different puncture site? Which one do you think will actually be the same? Okay, let's see. Some of you say stiffness, a lot of you say none of the above also. So the correct answer is actually stiffness and length. So you can see the ticks. The ticks are basically the right answer. So why is stiffness and length? Actually, length is the most obvious because if you see in this image, right, you can see that the distance from the access site up to the heart is very similar. So as we mentioned, femoral access is actually the traditional access site. Typically, that's what they use from the very early days of angiogram and angioplasty. But when we transit to the arm, it's actually not very difficult because the length is the same. It's almost the same distance from if you put your hand down, you realize that it's actually very similar in terms of where your radial artery and your leg artery is. So length is actually the same, and stiffness is actually very similar because there's actually no difference in requirements in TFI or TRI, whether you assess it through the groin or whether you assess through it through the radial. The stiffness of the device matters later, not so much on the access site itself. So actually no difference in the stiffness. For size, there's actually difference. As I mentioned, radial artery is much smaller. So the difficulty when we actually have to move to radial access is that your devices have to be finer, have to be smaller. Because your radial artery is smaller, it cannot take as big device as you can for your groin, for your femoral artery. Okay, so stiffness and length are the device properties that stay the same even when we move from TFI to TRI. So let's look at the general steps to CAG. So as you see, there's introducer sheath there, and now we put in a guide wire up to the heart and also a guiding catheter. And then as just now what we saw, we actually does this start with angiogram? Let me start the image video again. So first puncture, and then insert your insertion sheath. Put in your guide wire. So this is your guide wire up to the heart, up to not just the heart, the just the artery, the ascending aorta, and then they put this catheter through, following your guide wire. So all this, as we mentioned, it's monitored using fluoroscopy. And you saw 3 devices used here: the insertion sheath, the guide wire, and the angiographic catheter. Okay, so before we move on, just a recap again. So which angiographic mode is used for monitoring of the device advancement through the artery? So in this procedure, do they use fluoro? Do they use Cine? Or they don't care? They don't look at the monitors. They just insert. Okay, so I guess everyone is now familiar. So for device advancement through the artery, typically this is done through fluoro, right? I don't want to use Cine because Cine gives me very high intense X-ray. I don't need it. I just need to make sure that it's going up the correct way, up the correct artery. I don't need to see very finely, a very high quality where my devices are. Okay, so after the devices, as you see, is actually engaged to the artery. This is your left coronary artery. Then a contrast media will be injected through so that your coronary arteries can be viewed. There you can see just now, as I mentioned, there will be tapering in the arteries. That means at the proximal is bigger, distal is smaller. But in the middle, if there's a pinch, you know there's a blockage. So this is probably how the blockage will look like. Of course, you don't see in this high quality and this color. You'll see as what you saw just now in a black and white image. It's just a pinch. The pinch is basically where your lesion is. Okay, so like what I mentioned just now, so here you can see that in this angiographic image, this is again for your left coronary artery. You can see that the start of your left coronary artery is already very pinched. It's already very thin, right? And down this artery, you can also see another pinch. So typically, you can see here this artery is fine, right? It's not pinching anywhere. It's getting big to small very smoothly. But if there's any pinch, it means that there's something wrong and procedure needs to be done. Actually, a procedure may not need to be done. For example, this one, if they decide that the flow to the distal side is still okay, they will not actually treat it. But here, if they decide that, oh, this is a very important one, it needs to supply to this artery and, down for the heart, they may actually want to treat this artery. So it's not saying that every time they see a pinch, they want to go treat it. It really depends on the conditions. That's why later you will see they will basically analyze whether this is an important and how important is it to actually treat this artery. But anyway, we're talking about the steps here. So just now, the first 3 steps: introduce the sheath, the guide wire, and the guiding catheter. So after doing this, the guide wire is just to guide this guiding catheter up to the correct side, right? So what we'll do is you remove your guide wire and then engage the angiographic catheter. Engaging means that this is your, I know you cannot see, but basically this is your coronary cusp or your ascending aorta. What you will do is actually put this angiographic catheter at the opening of your coronary artery, right? Because you need to position it there. If you just put it in this ascending aorta, you will take image of, you'll be able to take image of, I cannot change the color, but you can only take image of this coronary, the aorta itself. You need to actually insert your catheter tip into the opening of the coronary artery so that you can take image of this. So basically that's the steps. You will remove the guide wire. The guide wire will never go into your coronary artery. You will then put in your catheter, the tip, through the opening, and then start your coronary angiogram. So very, very quickly, which angiographic mode is used when taking an angiogram? You use Fluoro or Cine to take an angiogram. I think this one, everyone should get it right. Okay, let me just move on. I think this is very straightforward. So definitely angiogram in an angiogram, we want to very closely analyze where the problem lies. We want to see where the pinch is. We want to see how the pinch looks like. So in an angiogram, we will always use the Cine. So they will use the Cine to actually take high quality images to get understanding on your coronary artery condition. Okay, so basically these are the steps from insertion sheath to the commencement of your CAG. So this is very, very general. I'll zoom in a bit more. So insertion sheath, basically just now you saw this, and this is how an insertion sheath is looks like. So basically it's a short hollow tube. It's there to allow other devices to be inserted and advance through the puncture site. So you know that with this short tube here, the guide wire can then go in, the catheter then can then go in. There's this valve which will stop blood from flowing out. It allows devices to be pushed in, but the blood cannot flow back out. So the patient will not keep bleeding throughout the procedure. Okay, so this image is a bit small, but okay, if I tell you that these 3 steps is basically the steps that introduce the insertion sheath into the patient's body, is it right? So the first step, we assemble this the blue device into this introducer sheath, put them together. That's called the dilator, and I'll basically then push this insertion sheath into the patient's body. Once I locate, that there's actually blood, then I will pull the dilator out. Is it right? Is this true or false? Okay, so a bit half-half. So if you see it very generally, it looks correct, but the answer is actually false. So why is it false? We don't actually puncture with an insertion sheath, right? The puncture, remember, is done with the puncture needle. So the procedure starts after the puncture needle is placed into the patient's body. You first puncture, you will find the where the artery is. You put a mini guide wire through, and with the mini guide wire in the artery already, you will then put this assembled insertion sheath into the blood vessel. So you don't use the insertion sheath to locate the artery at all. It's already located with your puncture needle. So the needle is used to puncture and locate the artery. Once it's done, this insertion sheath is then placed along the mini guide wire into the blood vessel. Okay, so we'll see it very clearly here. So the doctor here, he will feel the pulse. So now you see he holds a needle, right? So with this needle, he will try to locate an artery. So you'll be able to experience this, I think, in your hands-on, the puncture and the difficulty in trying to find an artery. Even in a blood draw, you know how difficult is it? You see how the doctor is trying to find. Basically, he's trying to move the needle tip slightly around to try and see where the artery is. He will know when when he hits the artery, when there's a backflow of blood. Later you'll see the blood will be seen in the transparent hub. I think that he got it. So once he sees the backflow, he will put the mini guide wire in. Be blur. But mini guide wire in. And that's how he punctures and locate the artery with the puncture needle. Now he removes the puncture needle. And he will put the assembled insertion sheath through the mini guide wire. So that's how the introducer sheath is actually introduced, right? After the puncture needle through the mini guide wire. So he will now push this insertion sheath or introducer under the skin into the blood vessel until the whole shaft is actually in the under the skin. And then he removed the dilator and the guide wire. So you see that actually blood is not flowing out, continuously through here. It's not, because there's a valve here that stops it from happening. You can see that he removes the device. Devices can be placed through this insertion sheath, introducer sheath, but this introducer sheath will also stop blood from actually flowing out, so it prevents the patient from bleeding throughout the procedure. Okay, so that's the very first step, which is to introduce the insertion sheath. Okay, so now what's happening? This second operator is actually preparing the diagnostic catheter. So he flushes it, and then he now put in a guide wire through this diagnostic catheter. So he put in through the whole length, and then now he passed the tip to the first operator. So once he sees that the first operator inserted the diagnostic catheter into the sheath, he then advances the guide wire. And now we will look at the monitor. So observing under fluoro, you can see the wire in the ascending aorta forming a very, very big loop, right? And then the first operator is also advancing the diagnostic catheter to the ascending aorta. So once they do that, once the diagnostic catheter is in this ascending aorta, this second operator is going to remove the 035 wire. So just now in a very big picture, it's actually very simplified, but the more accurate step is what you're seeing here. This is actually done on a real patient, right? So after the introducer sheath is inserted into the body, they will actually then assemble 035 guide wire and the angiographic guiding catheter. So assemble, it also later we'll mention lah, but basically all of these steps will require priming. We need to prepare the each devices, flushing it with saline, heparin, dipping it in the devices, dipping it into the solution, so that as you remember just now, to prevent blood clotting, to prevent introduction of bubbles, air bubbles into the blood vessel. So once this is assembled, they will advance the angiographic guiding catheter. The guide wire is always ahead, because later you'll see angiographic guiding catheter has a shape at its tip. So we want the guide wire to make this tip straight so that it doesn't damage your arteries. So once this guide wire guiding catheter is in the ascending aorta, you will then remove your 035 guide wire. So now the operator will try to rotate the diagnostic catheter. So he's rotating, right, to try and engage or to put the tip at the coronary opening. So he will try to rotate, and then at this proximal end, the distal tip will turn. Let's see, the distal tip here will turn. And if he thinks that this tip is at the correct position at the opening, he will then prepare to check using the contrast media. Okay, so that you can see the catheter there. This is if I draw here, this is the catheter, right? This one. Basically, this is the catheter, and now he will actually now inject a bit, right? So he realized that, oh no, I don't see the coronary artery, so he's gonna turn this catheter a bit more and inject again. So now he's not taking fluoro, he's not taking Cine, so you cannot see the image moving. But okay, now he's on fluoro again. So he's gonna turn the catheters until he actually, then you see a coronary artery. So it means that this tip is engaged at the ostium, or the opening of the coronary artery. So he very successfully engaged this. This is actually the right coronary artery. So if you miss the angiogram on the video or cannot really identify the structures, I drew this image here. So in red, you can see the aorta, and basically this is the opening, right, to the coronary artery. This whole length is the artery. So this side is the opening, and in blue, the diagnostic catheter is engaged to the ostium. That's why, since the tip of the catheter is at the opening, you can actually then take an angiogram very clearly. So this is called the engagement. So when I say engage the guiding catheter, it just means that this guiding catheter's tip is at the opening of the coronary artery. He is sure that this ostium is engaged, right? What he does is that he will get the C-arm in the correct position, then he will take an angiogram under the Cine mode. So he will use a high pulsed X-ray to then take a angiogram. So what you have watched is actually the real steps of the introduction of this insertion sheath all the way up to taking an angiogram, as you've seen here. Okay, so you saw that the doctor now took one angiogram image of the RCA, which is the right coronary artery. What do you think the doctor will do next? He already do all the steps, and he started his angiogram. He took one image. What is he going to do next? Is he going to take change to the left side to take angiogram image of the left side? Is he going to take more angiogram images of the right coronary artery, or does he see, oh, I have a lesion, I have a problem, I will treat the right coronary artery now? Which do you think the doctor will do? Okay, so half of you think that they will switch to the left coronary artery, and the other half is sure that you will take more angiogram images of RCA. So the correct answer is actually to take more angiogram images of the RCA. So you typically you will need from multiple angles, as I mentioned just now, from the angiographic angles. For RCA, you don't take a lot of angles, but you still take some angles to actually view it correctly. And then you will move, if the patient, if you don't identify problems, or if you want to take a more complete image, then they will move to the left coronary artery. Same thing for left coronary artery. They will not just take one image. They will always take multiple images from different angles. The C-arm will move up and down, left and right, from different angles to actually very correctly identify the problem. They will definitely, I think all of you realize, they will not start the treatment after just one image. Okay, so as I mentioned, typically for like right coronary arteries, they will take different views so that they can actually see the different parts of the coronary artery. You realize that actually what you're seeing here, these three images, are the same coronary artery. It's just that it's from different angle, so it looks very different. And that's the importance of actually taking a different view. So when you see them doing angiogram, it's not so fast. Once they engage, they take one angiogram image. They will then keep taking images from different angles to really identify the problem very well. Okay, so in this case, after taking the RCA, then they will want to move to LCA. So in this case, they will disengage. So they will take out the diagnostic catheter tip from the opening, and they will advance the guide wire. Then the diagnostic catheter will be removed. So now the second operator is preparing the second diagnostic catheter. This is probably for the left coronary artery. Now then he inserts again the guide wire into the diagnostic catheter. So same step for the left coronary artery. So he will pass the tip of this diagnostic catheter, because there's actually the guide wire in already. So he's not assembling, he's actually just backloading this second diagnostic catheter into the existing 035 guide wire. So he gives it to the first operator, who advances it into the ascending aorta again. And again, if the diagnostic catheter is already in the ascending aorta, I don't need the wire to guide my catheter anymore, so they will pull out the guide wire. So here you see, second operator observe the monitor is already in this ascending aorta, so I'll pull it out, and then the first operator is trying to rotate again to engage the tip to the ostium, to the opening of the left coronary artery. So here, again, they're gonna take full contrast, and I think he engages this very quickly. Once he managed to engage well, they will start the angiogram for the left coronary arteries. So from the videos that you saw in the cath lab, right, you observe that the doctors switch from the diagnostic catheter when they move from the right coronary artery to the left coronary artery. And that's because there's actually dedicated shapes for these diagnostic catheters. As I mentioned, the diagnostic catheters or guiding catheters are not straight. They actually have these shapes because they need to actually be engaged to the coronary ostium. And to go to the left and to go to the right, it's actually different shape. Okay, so that's why when they move from this is your LCA, this is your left coronary artery, and this is your right coronary artery. When they move between this, they will have to change diagnostic catheter. Yeah, okay. So basically this describes the whole steps of the procedures for CAG. So CAG, you realize that it's quite straightforward lah. Basically, introduce the insertion sheath. Once the 035 and 135 guide wire and angiographic guiding catheter is assembled, you advance it with your 035 guide wire leading, and once your guiding catheter is in the ascending aorta, you will remove your 035 guide wire and engage the angiographic catheter to start your angiogram for one of your coronary artery. So when you want to take after you have taken your images, multiple images for your right coronary artery, you will want to take a left. So you have to disengage. Disengage means removing the tip of the catheter from the opening of the ostium. So that's disengaging. Once I disengage, I will have to advance my guide wire again. Again, why I always have to have my guide wire first? I need to make sure that the tip of my guiding catheter is relatively straight. If it is bent in this shape, right, you can imagine when you go down your artery, this shape will just keep scraping your artery. So that's not very ideal. We want to try and maintain it as straight as possible to remove and insert the catheter smoothly. So this guide wire is always in front of your guiding catheter. Okay, so I will advance this and then remove my angiographic guiding catheter. You realize that I didn't remove my 035 guide wire. I didn't remove my guide wire in this step because I want to take my left coronary artery image. So I will leave the guide wire there. I just remove my guiding catheter and I insert the next guiding catheter that is intended for my left coronary artery. So I will advance it until it reaches the aorta, the ascending aorta, remove my 035 guide wire and engage this angiographic guiding catheter for the left coronary artery and commence CAG. Okay. So actually this is that's about it for CAG. So once for angiogram, once I finish taking my left coronary artery images, I will disengage the angiographic guiding catheter, again advance my 035 guide wire so that I can remove my guiding catheter safely, and then I will close my puncture site. After you have to remove your insertion sheath before you totally close it with different kind of methods. As I mentioned, you can do manual compression. There's dedicated device that closes your puncture site. If you use a radial, it's just a band. It's a very simple band that helps to put pressure on the puncture site so that bleeding is stopped. So that's it for CAG actually. For angiography, which is the diagnosis part. The whole point of a diagnosis or angiogram is basically to take images so that I can see where the problem lies. It is not for treatment. It is not for to solve any issues. It is just to identify the issue. So CAG steps also pretty straightforward, but once you get it, PCI is actually very straightforward. So no questions for me. Let me very quickly finish PCI before we have a break. I think PCI is much straightforward. So I'm not going to go through this in detail. Basically, this kind of describes how after your angiogram, when do they decide whether they should move to PCI? When should they move to a treatment? So these are all based on guidelines or based on the associations. Like if they decide that there's a guideline generally, if they meet this kind of criteria, if there's a left main disease, if specific criteria are met, then PCI is strongly recommended. Or revascularization. Actually, they don't just say PCI because there's another solution for revascularization. Revascularization means if your vessel is supposed to look like that, but there's a lesion here that is causing the blockage, your vessel is gone, right? So to revascularize means I remove this lesion. So I try to allow the blood to flow again. So how to allow the blood to flow again? PCI is just one option. PCI is the percutaneous coronary intervention, which means that later I'll talk about the treatment. But another alternative revascularization to allow blood flow again is basically to put in grafts, right? This is CABG, stands for coronary artery bypass graft. So bypass graft meaning you take an artery typically from your leg or somewhere else and attach it to the main artery, down to the distal. If this side is blocked, right, you just connect this to this and then I have blood flow again. So this is another method for revascularization. But CABG, cabbage, is not done in interventional in a cath lab. This is actually done by surgeons. So this is basically an open heart surgery versus a intervention procedure. So what we are looking at is actually the intervention procedure. And even after we decide that PCI is going to be done, that we are not going to do cabbage, they will actually then determine which stage are you in. There's typically a heart team in your hospital who will decide, whether we should proceed with the treatment, because there's always going to be risk associated with treatment. Any kind of procedure, CAG, there's some risk, not so much, but when you move on to treatment, the risk is much higher. Okay, so typically you need to make a decision, and the heart team will basically help to analyze and weigh the benefits and the disadvantages. Of course, your patient will have some decision-making power. You need your informed consent from your patient. Sometimes it depends on what kind of stage your condition is. If it's a very emergency case, like it's a heart attack, there's actually not much time to make a decision. PCI revasculation, you need to do it emergency. You need to do it immediately. You shouldn't delay at all. It can be determined as an urgent case. Some of them are considered like stage. That means I think you need this procedure, but you can come back 2 weeks later and do it again. You don't need to do it immediately. So you can actually plan for such procedures to be done if your condition is not so serious. Okay, so for the last one, it just means that in your coronary arteries, there's different branches, and not just one branch may be affected, maybe other branches are affected, but to different extent, to different degrees, to different impacts. So it doesn't mean that if I want to treat, I treat everything. That's because, as I mentioned, treatment has its risk. So they may not actually want to do that. They may actually just treat the most important ones and leave the rest as it is. So yeah, all these decisions have to be made, and you will hear discussions of this in the cath lab. Okay, so what I would like to cover is basically PCI. So after your doctors decide on the procedure, basically what you'll hear is let's proceed with PCI, which stands for percutaneous coronary intervention. In the past, it is known as PTCA or percutaneous transluminal coronary angioplasty, PTCA, but or angioplasty with stent. It is not so commonly used now, but okay, angioplasty is sometimes still used lah. So you need to remember that when you talk about angioplasty, it's different from angiogram. Angiogram is an image. Angioplasty is your PCI procedure. Okay, so angioplasty is actually still used, or simply known as treatment or interventional treatment. So these terms are all interchangeable in for PCI. So here, you will probably see this very familiar. As I mentioned, if you know about CAG, if you know your diagnostic procedure, PCI flow actually follows it very, very closely. First, of course, you will need to decide on your access site, whether it is transfemoral or transradial. You will puncture with a puncture needle, insert the insertion sheath so that then your guide wire and guiding catheter can go through. And for CAG, you will then, once you take your coronary angiogram, you will then close your access site with a hemostatic device, which means to stop the blood. But for PCI, these two are the additional steps. After you put in your 035 guide wire and guiding catheter to take your angiogram, you will remove this guide wire and guiding catheter, and what you will do is not guiding catheter. Guiding catheter stays there. You will put in your guide wire and also your balloon and stent. So let's see the procedure in image. So as I mentioned, guiding catheter stays there. So guiding catheter is still required because you need your catheter tip to be engaged to your coronary ostium. So this is the left coronary ostium, your LCA. So you have a lesion here, and your catheter is engaged. So now you will insert 014 guide wire. So just now when we talk about diagnosis, you will here 0.035. Normally I just call it 035. Typically in field you also call it just 035 or 014. This just means the diameter of the guide wire in inch. And as I mentioned, 035, right? It only comes in the aorta here. It will never go into your coronary artery because it's thick. It's a bit stiffer. It's a bit more higher risk of piercing through your coronary artery. So we typically don't put such a thick and stiff wire into your coronary artery. What we use in your coronary artery is this 014 guide wire. So I will insert and cross the lesion. So this is called the lesion, where the pinch is. And once my guide wire is there, I will leave it there so that my treatment catheter, it can be balloon, it can be your imaging device, it can be your stent, any kind of treatment device can then be threaded over your 014 guide wire and push it through the lesion. So just now this is a balloon. So now I'm going to inflate it. I'm going to treat the lesion site, deflate it, and remove the treatment catheter. So as you see, actually, once you get your what's that called? Your angiogram, right? This is actually then very straightforward. Basically, very similar to what you saw in your CAG. Once your angiographic catheter is engaged, you do your CAG. Once your CAG is done, you will disengage the angiographic guiding catheter to advance 035 guide wire, remove the angiographic guiding catheter, because I'm not going to take angiogram again, right? Angiogram already. So now what I need to do is to exchange for a treatment guiding catheter. Okay, so there are three things that you see you're different from additional from a CAG. You will see treatment guiding catheter. Once the treatment guiding catheter is in, I will remove the 035 guide wire. I don't want it anymore because I'm not going to put it into the coronary artery. What I will advance is this 014 guide wire. And once I insert the 014 guide wire into my coronary artery through the lesion, I can start my PCI by advancing treatment device. So basically, you will see different 1, 2, 3. In PCI, you will see treatment guiding catheter. You will see 014, a thinner, finer guide wire, and you will see treatment device. So I'm going to move deeper into what's the difference. So the first difference, of course, again, you will see a treatment device, a treatment guiding catheter used instead of a angiographic catheter. Okay, so there's slight difference in these properties of a treatment guiding catheter and angiographic catheter, because you know that for angiographic catheter, guiding catheter, what it does is basically it carries the contrast media, right? So basically it supports the injection of your contrast media to take CAG. That's it. That's the role for angiographic guiding catheter. But for treatment guiding catheter, it has to support different kind of treatment device. Later you'll see it needs to actually support the balloon catheters, the imaging catheters into a lesion which is tight, right? It's causing a lot of resistance and um, and because of this difference in functions, the properties are very different. So there's actually a difference between your angiographic and your treatment guiding catheter. So I didn't really reveal the answer maybe, but which of the following device property do you expect to be the same? So not different, same for angiographic and treatment guiding catheter. Yeah, I did not reveal the answer, but if you think about the procedure, what is actually the same for angiographic and treatment guiding catheter? Okay, I'm gonna reveal the answer. So now all of them have some answers. Most of you say length. Actually, if you talk about similarities or the exact same thing about angiographic and treatment guiding catheters, the same thing, the common thing that is between them is the length. As you know, angiographic and treatment guiding catheter, their starting point and ending point is the same. They start at the same access site, they end at the same opening of the coronary artery. That's why the length is actually exactly the same. But other than that, typically they are different. Treatment guiding catheter is typically stiffer than an angio diagnostic catheter because since the diagnostic catheter is just to inject the contrast into your coronary arteries, you don't need to be so stiff. You don't need a lot of strength from the guiding catheter to support anything. But treatment guiding catheter needs to support the devices that go through very, very, very small places, small spaces. So, when you push your device through, if you have no strength, no stiffness in your guiding catheter, it keep disengaging. That means the tip keep coming out of your opening and your procedure cannot proceed. So typically treatment guiding catheters are stiffer as compared to an angiographic catheter. For size-wise, none of you say that it's the same, which is true because again, angiographic catheter just inject contrast media, right? I don't need very big diameter angiographic catheter lumen. The tube itself, I don't need it to be very big. But for treatment, I need to put in balloon catheters, etc. So I need a specific size I need a big enough size treatment guiding catheter to actually allow for treatment. So the only same property between angiographic and treatment is actually the length. Okay, so that's the first difference. Basically, in a CAG and a PCR procedure, the first difference is the guiding catheter that is used. Second difference, I think just now I've mentioned, 014 guide wire. So 014, as I mentioned, it just means your diameter of your guide wire is thinner, it's finer. It's 3 times lesser, right? It's 035 versus 014, about 3 times, 2 point something. So this purpose of the wire is to go into the coronary arteries and it needs to cross the lesion. You remember how the lesion is, it could be quite tight, right? So you basically need to go past in here. So this fine wire is basically to do that. It provides a track, right? Like for trains, right? It provides a track so that the treatment device can go over this wire and through the lesions to be able to treat this lesion. And finally, definitely you need a treatment device. I think this is quite straightforward. Balloons and stents are basically your essential devices in your interventional cardiology for CAD, but there are others which I will introduce a bit later. So yeah, basically this will form the PCI general steps, especially in elective or stage cases. So again, these terms may be quite new to you. Elective and stage cases means that the patient's condition is not very serious. So after your diagnosis, after your CAG, maybe subsequently, 1 month later, the patient come back and say, oh, okay, let's proceed with the treatment so that I won't get the heart pain, once every 3 weeks or so. So they decided to go with this procedure. And even if they come back 1 month later, they will still actually do CAG. They won't say, I will skip. I think it's correct. They will always still do this just to confirm that this site needs to be treated before they proceed. So these steps are typically for such cases, for elective and stage cases. But what if I say that this patient is an emergency case? So emergency case, right, means I don't want the steps to be so long. What can I actually skip? What steps or device can I skip from this PCI general steps? Let's say this is an emergency. Just now I described a case where the patient come back 1 month later. You can slowly do, doesn't matter, you can slowly go check your angiogram, etc. Not slowly as in relatively lah, but for emergency case, the patient is having a heart attack. That means the vessel is blocked. The blood cannot flow down to support the heart anymore. I want to be as fast as possible. Which steps will I step, or which device will I skip? So which one do you think? The CAG step, they just don't CAG, they just, I don't know how but they just do PCI. They don't do PCI, they do CAG. They don't use angiographic guiding catheter, or they don't use a treatment guiding catheter. Which one will they miss or skip? Okay, I think most of you got it right. When an emergency case happens, sometimes you will not see the angiographic guiding catheter being used, because although there's a difference between angiographic and treatment guiding catheter can still be used for CAG. So to save time from this exchange, right, from this angiographic catheter to treatment guiding catheter, sometimes they just don't use the angiographic catheter, especially in an emergency case. So they will just basically do this insertion shift. Of course, you put in your guide wire with a treatment guiding catheter. Emergency, that means I know I need to treat already, right? I won't stop just to take an image. I will basically, once I put in my device, I'm going to start taking my angiogram, and after the angiogram, see where the problem is and treat the problem immediately. So so I will put in my treatment guiding catheter, and then remove the guide wire, engage it, check CAG. CAG we still do. My pen not working anymore. But CAG, they will still do it, and then they will advance the 014 guide wire and then do PCI. So basically, angiographic guiding catheter, it's used commonly, but in an emergency case, sometimes you will see it being skipped. So this is called an E case. How come the video doesn't play? Okay, so basically, again, let's see, basically the 014 wire is put through the lesion, and the treatment device is threaded over the guide wire, is then treated. So here you see a balloon being expanded at the lesion site. And what happens is here they try to compress the lesion so that the vessel size get bigger, right? So just now you see this vessel size, my pen not working anymore, sorry. So basically a lesion at the yellow area, you see that the vessel size is smaller, but after the ballooning, you can see the vessel size regaining its diameter. So that's how that's one way that treatment could be done. But I'm going to go through the steps first. Basically, one thing to consider. So I know that we keep emphasizing that for 0.35-inch guide wire. It is removed after diagnostic catheter is advanced into ascending aorta. So do you think that this 0.14 guide wire, which is the treatment used in treatment, will it be removed after the treatment device is delivered to the desired position? Which means that, I got my mouse right. So now you see that this is my treatment device. Just now you saw my treatment device is the balloon. The balloon will expand and, you know, compress this lesion so that the vessel will be bigger. But during this procedure, do you think the 0.14 guide wire should be removed or should stay in place? Okay, most of you got it right. Actually, the answer is no. It doesn't really depend. So why they actually put in the guide wire? So this guide wire is there so that if anything goes wrong, for example, if something happened to the balloon, I don't know, but sometimes the treatment doesn't work. For example, if I put in my balloon, I try to actually expand the lesion, it doesn't work. Then what happens if your guide wire is not there? You know that this lesion, this diameter here is very small. Guide wire is thin, so it can pass through. But sometimes even guide wire, it takes very long. Actually, the longest procedure is typically to put this wire through the lesion. Most of the time in your cath lab, you'll probably just see the doctor trying to push the guide wire through the lesion. That's usually the most difficult part because it's so tricky, right? The guide wire is relatively thin and soft. You need to push it through here so that treatment device can come here. So typically once your guide wire goes past your lesion, crosses your lesion, they don't remove it at all. They will make sure that it stays there until my treatment is done, until I do another CAG, and then I will remove, because otherwise if something goes wrong, I'll take another hour just to try and wire my lesion, wire through to cross the lesion. So they typically don't remove the guide wire when they are doing the treatment. Let me see another video. So that was a balloon. So let's take a look at angioplasty with a stent, which is PCI with a stent. So 0.14 wire again. So this stent catheter is advanced through the lesion over the guide wire. And what happens in a stent angioplasty is that the balloon that has a stent on it will basically be expanded. And when the balloon deflates, the stent will actually remain in place. So this stent will stay in the body and helps to maintain this vessel diameter, right? So this stent is basically a structure which helps to maintain the vessel diameter at the lesion site. So for a fact, actually more than one treatment device is used in a PCI procedure. Not so much of treatment device, but yeah, you say if I say considered balloon and stents, they're all treatment device. Typically, more than one is used in a PCI procedure. Do you think that for each procedure, will the guide wire be removed every time I introduce a treatment guide wire, treatment device? So that means, let's say I put in a balloon first, I put in wire, I put in balloon. So I open the balloon and then now I remove the balloon, I remove wire. Then I put in another wire and then I put in another treatment device. Do I do that, or will the 0.14 wire be maintained as much as possible? So again, actually this answer is usually more often than not, no. So this 0.14 guide wire is not removed with treatment device. Depends can be a right answer because sometimes they change the guide wire for a different for one with a different property. But typically it's not true lah, because they want the wire to stay there as much as possible. Once this wire is, you know, crosses the lesion, they will make sure that it stays there until as I mentioned, until the end of the procedure, because sometimes it's really very hard to cross the lesion. So once I get it through, I will not touch it anymore. So typically the answer is no. Every time there's a treatment device, they will still use the same guide wire, because you realize I say 0.14 guide wire because they won't use different size of guide wire throughout the procedure. The treatment devices are more often than not compatible with 0.14 guide wire. So that's one reason why they don't also change the guide wire with each treatment device. The treatment device are all compatible with this. So once the guide wire passes through the lesion, guide wire will not be changed. Okay, so for PCI mechanism, just now you saw a balloon in action. So balloon is actually the most common PCI treatment device. It is used for a different purpose. So it's shown here. The first one on the left is dissection. So it can dissect very hard lesion. If it's a very fibrous lesion, it can stretch it, right? It can stretch it so that the vessel size increases, or it can compress it. If this is a very soft lesion, it can compress it like fats, like fatty lesion, it can actually compress it. But nowadays, it is not typically used as a standalone. Like I mentioned, there's more than one treatment device used in a procedure. Typically, balloons are used with stents like this. So stents, just now you saw it in action also. Stents are basically devices that is used to open the vessel and to keep it open for long periods of time. Actually, it will stay in your body forever. The usual stents that you see are going to be in the patient's body forever. So it will help to maintain the vessel diameter by actually using its mechanical property, right? This is actually by dissection, stretching, or compression. But once it's done, I will actually remove it. What happens is sometimes the lesion, it's soft, you compress it, right? But it can come back. So stenting basically has this mechanical metal structure that keeps it open. And I don't have an image here. I don't have an image. If you have your notes, it's okay. Let me skip this question. So other treatment devices are as such here for atherectomy device such as rotational or laser. This is actually to remove plaque. So just now I mentioned for balloon and stent, they are typically for softer fibrous, some hard tissue, but actually for atherectomy device, these are used for lesions that have calcium. So you see the white layer, they're actually calcified lesions. So they're very, very hard. If you put a balloon there and try to expand it, it may not happen. Nothing may change because there's a cap, right? There's a cover over the lesion, which prevents the balloon from taking its effect. You try to open it, it doesn't move because the balloon is not as hard as the lesion, as the calcium. So what happens here is that you need a device. So it can be a rotational device, it can be a laser device that helps to break, debulk this lesion. So you can see once this is a rotational device, once it shaves off the covering, the calcium cap, then the lesion that is softer, that is more fibrous is exposed. So I can put balloon through to kind of compress it. Then I put a stent through to actually maintain the vessel diameter. So that's how the atherectomy device works. And finally, there's this treatment device called the thrombectomy. Thrombectomy actually removes the thrombus. So it aspirates or it vacuums out this blood clots. So in a PCI procedure, sometimes your heart attack is caused by the lesions bursting. So once the lesions burst, it releases blood clots into your arteries, and these blood clots will then block your artery. So thrombectomy is one of the techniques that is used to remove the blood clots by a vacuuming system. Later, I will also show you in detail how actually aspiration catheter can work. Okay, so after the treatment device, so we went through the PCI general steps on the top. So after using this treatment device, some further steps may be required before completing the procedure. So the device will be removed, treatment results will be confirmed by CAG. So remember, I need to, as I mentioned here, so I will always, after I remove the treatment device, I typically don't remove my 014 wire. I will check my angiogram first, just to make sure that everything is fine. and then I will remove my 014 wire, and then disengage the treatment guiding catheter. Then same step. Once I disengage, I need to advance my guide wire that is 035 because I want to straighten my treatment guiding catheter. I don't want the tip to actually damage my arteries. So I will actually now advance it to remove the treatment guiding catheter and 035 guide wire, and then remove insertion sheath and close the puncture site. So basically, this is it for PCI procedure, and also CAG. So I know that the steps here is a bit difficult to understand, I guess, because although we saw videos and we go through the steps in details, um, it's still best to be able to actually observe the case in person, which I think you will probably have the opportunity to, and in the next few weeks you'll probably get the opportunity to try it on a vessel model also. So on the vessel model, we will be able to give you the experience of a kind of puncture site, how to puncture, how the guide wire and angiographic catheter should be advanced and moved up a vessel model. This vessel model will simulate the arteries and your heart, coronary artery. So you'll be able to experience this, and I hope that you'll be able to appreciate that better with this theory in mind. So whatever I went through today is of course very theoretical. So don't worry too much if you cannot follow very closely. Just keep this in mind. You just remember the terms, remember the concepts, and when you do your hands-on on the simulation on the vessel model, I'm sure you will be able to actually understand and appreciate it even better. Okay, so I've been talking for 2 hours, so I don't know how much you can absorb. But the next lecture that I'll be going through is on the device side of things. So on the device side of things, it is more theoretical lah. So I hope we can go through it in an hour, but let's take a 5 minutes break, and we'll come back. What time is it in? I think it's we come back in 5 minutes. So it's 3:05, I think, in Thailand. So we come back 3:05, and then we'll move on to the last lecture, which is on devices. Okay, so I'm not so sure whether you have any questions. Let me check. Yeah, but you can take a break first, and then we will, if any questions, I will answer after the break. Okay, if you're back early, you can let me know if you have any questions. You can voice it out, or an exercise that you can do is to write down the keywords that you remember from the procedure lecture. So just now we talked a lot about the procedure. So from the general procedure to CAG to PCI. So we can actually create a word cloud here. So basically any kind of words that you think it's important in the lecture, you can write it down. Don't write an essay, just write a few words. You can submit a few times, so you can go on your Slido again to submit. Yes, to submit keywords that you think it's important that we should know, that everyone should know, so everyone can remember what kind of words, what kind of things to pay attention to when they look at interventional cardiology for coronary artery disease. What's 314? So I guess I can very quickly run through again basically what is important as you mentioned here. So basically coronary artery disease, we need to know for general procedure, we definitely need to know in the cath lab how the setup is like. We need to know about CR. We need to be able to protect ourselves and protect our patients by knowing what kind of attire to wear. And of course, you need to know what the nurses are doing, what the nurses are looking out for. So that's the very, very general things that you need to know. For CAD, not CAD, for CAG, for PCI, definitely you need to know the assess site. So you need to know what is TFI, what is TRI, how they assess, what devices they use to assess. I don't see the word for device to assess yet, but insertion sheath, you need to know that this is used for assess. You need to know that angiographic guiding catheter is used with O35 guide wire. I don't see it here, but O35 guide wire should be used with your angiographic guiding catheter and of course your treatment guiding catheter to engage your catheters to your coronary ostium. And once you are at your coronary ostium, of course, you can take your angiogram. Angiogram, you need to take note when you need to do Fluoro, Cine. Your doctors will probably call for it, but you need to know what it means. Fluoro generally means that you are taking you are taking something that's not so important. It's just tracking the device advancement, etc. Cine is when you are taking an angiogram. And subsequently, once you engage your treatment guiding catheter, once you engage your angiographic guiding catheter, you will do your contrast media injection so that you get your angiogram. Once you identify a problem, you may or may not go to PCI. If you go to PCI, important devices are your 014 guide wire, your treatment guiding catheter, and your treatment device. So treatment device can cover from your balloons, your stents, your atherectomy devices like rotational or laser devices. It can also cover thrombectomy. Okay, so yeah, so I hope you basically get some learnings from this lecture, the exact procedure, how you're going to handle, how you use it, how doctors do it. You'll be able to experience it in the simulation model. Okay, so let's move on to the device. This one, I won't go really, really in depth because I really, this one you'll probably be able to, it's very boring if I go through very in depth because it's quite easy to actually just look through the notes and understand what it means. So I'm going to go through very, very quickly how, some important specifications that you hear about devices and how some devices should be prepared. Before I go into key specifications, one thing I would like to highlight again is how they prepare. So I will later go through how priming is done, but take note that saline with heparin is always used in the cath lab. So on the trolley in the cath lab, you will typically see a tray with liquid inside, basically your saline with heparin. So devices are typically not used once, especially your wires, your guide wires, and your guiding catheters. So after they are used or before they are used, they are typically soaked inside. So this is how um, your bubbles, your air bubbles, your air dead space within the catheters can be maintained, like can be removed. So it can be kept wet all the time. So that's in between procedure. So I won't go through for each devices. Like for your guide wires, they will put this guide wire into the bucket of into the tray of your saline with heparin. It always happens. So for all devices, once they are used, if they want to, before using, they may also dip it inside. So this is one thing to note. And why do they do this? Again, they don't want blood clotting to happen on the surface or inside the device, and they don't want, for like catheters, the tube devices, they don't want dead space inside. They want it to be wet throughout so that air will not be introduced into your blood, causing a blockage. Okay, so that's a very, very general thing about devices. Again, about the keeping the devices, priming the devices. So that's general one. Later I'll go into more specific ones that talks about priming of new devices. Okay, so key specifications before. Later when I go through each device, you will see this measurements being used commonly. So for device size like sheaths or shafts of catheters or wires, it can be in this metrics mode, cm, mm, or it can be in US imperial inch or medical measurement French. Actually these are all used. I won't say that in which country this is used. They're all used. So some yeah, it's used interchangeably lah. So you have to get used to it. Certain things like your catheter size is always in French. So French is actually it's actually devised by a maker of surgical instruments. So that's why it's a medical measurement. It's a bit tricky, but okay lah, once you get it, it's quite straightforward. 1 French is 1/3 mm. Let me see whether my pen is charged now. Okay, so 1 French equals to 1/3 of mm. So basically 6 French equals to 2 mm, right? So yeah, so typically what we hear is that this French guiding catheter is compatible with this French insertion sheath is compatible with this French guiding catheter. So it's important to know such measurements, basically to allow operators to know about compatibility of devices and whether it suits the patients. So as I mentioned, just now I say that 6 French guiding catheter is compatible with 6 French introducer sheath. That's how I know compatibility. If they tell me 2 mm is 2 mm, it's a bit 2 mm is compatible with 6 French, it's very confusing. But once I know this is a 6 French guiding catheter, then I will be able to take a 6 French introducer sheath and use it together. So if you think about it, does a 6 French here refer to the inner diameter of both the guiding catheter and introducer sheath? Is it true or false? So you need to know that there's outer and inner diameter, right? Guiding catheter is, if you remember, goes through the introducer. Actually, everything goes through the introducer sheath. Introducer sheath is at your access site, and all devices go through it. So I say that 6 French introducer sheath is already at the patient's in the patient's body. So now I want to put in a 6 French guiding catheter. Is this 6 French referring to both the inner diameter? No, doesn't work. Oh, 50-50%. So actually the answer is false, and this is a definite answer. There's no depends. So why is it false? As I mentioned, guiding catheter goes into an introducer sheath. So how they take this 6 French is compatible to this 6 French is that since guiding catheter goes into introducer sheath, 6 French of a guiding catheter refers to the outer diameter, so that it can go into a inner diameter of a 6 French introducer sheath, right? So that's how these two devices are compatible. How? Because you need to know that compatibility is considered when the devices are used together. So you need to know which device goes into which device, and then you will realize that, my inner diameter of the introducer sheath should match the outer diameter of a guiding catheter, and both of this refers to the 6 French, right? So that's how compatibility works. Okay, so device size for balloons or stents, especially for small devices, are usually in mm, and it is typically used to let operators know whether the device is wide enough for its intended purpose. So as you see here, this sign refers to diameter. I'm not so sure you know. So normally when you see a diameter of 4 mm, for a balloon, it just means that the balloon can expand up to 4 mm, similar to stents. And length for sheaths, shaft of catheter, wires, balloons, or stents is also mm, but for longer devices, cm, and also basically allows operator to know whether the device is long enough for its intended purpose. Pressure can be in ATM or PSI, and it allows the operator to know the proximal expansion of the device to specific diameter. So typically how you see this is the balloon can be expanded to 16 ATM. 16 ATM will then relate to a diameter of 4 mm. So that's how you will see these measurements being shown. Okay, so the first product category I will elaborate on is access. So access products are used from the access site up to the ostium of the coronary artery. So basically, these devices provide access for other devices to enter the coronary artery. And so from the access site up to coronary artery, right, so basically includes introducer or your insertion sheath, diagnostic guide wire, diagnostic catheter, and your guiding catheter. So the introducer itself, it's I always refer it previously as insertion sheath. It can be called an introducer sheath, insertion sheath, or a sheath simply. I tend to use introducer a lot because it's quite straightforward to remind myself that this device basically introduces other device into the patient's body. So this is known as an introducer. So key functions of introducer, I think you probably already know. The first thing is to be able to provide access for percutaneous introduction of device throughout the procedure. And of course, second thing, I need to maintain hemostasis. I need to make sure that the patient is not bleeding throughout the procedure. So 2 functions, and that's how the device is designed. Basically, it's a hollow tube. Here, the sheath itself is a hollow tube, right? It has this valve, hemostasis valve at its proximal end, and that's basically the simple part of the introducer. But to make the entry into your vessel, into your skin smooth, you need this dilator. Otherwise, if you just introduce this into your skin, it's going to be very painful. So you will have this transition so that you can actually transit very nicely into your skin with minimal pain. Mini guide wire, again, it leads the introducer into your skin. There's this side tube with 3-way stopcock, and this is typically used for the device to be primed, right? So otherwise it cannot be primed. There's no way that you can prime it. So this one, basically with a 3-way stopcock, you can actually put saline solution and then prime the device through. Again, I don't want any kind of, I want to wet the device. I don't want the device to have any introduce air into my body. So key specifications, you can find it on its label. Introducer, basically you will see its sheath size. Typically it is 5 to 7 French. You will see a technical drawing typically, so it's very straightforward. Once you see the label, you will be able to understand. So you will be able to see details such as the sheath length. So it's typically 10 cm. And you will see here the inner diameter, which matches with the compatible mini guide wire. So this is the mini guide wire, and it typically comes with the device as a package. So the mini guide wire is indicated as E. So SE, yeah, here that's a mini guide wire. But D, so for example, 0.21 is your diameter of your mini guide wire, which matches your B, which is your inner diameter of your introducer sheath. So yeah, basically then you will also see what kind of guide wire is actually provided. And this is quite important because plastic or spring, basically plastic means that if you use a metal needle, you may actually shave off the plastic wire, right? So you need to know whether it's plastic or spring to know what kind of needle you should use. So if the needle doesn't necessarily come with the package, because the doctor can use his own needle to do the puncture. But we need to know whether this guide wire provided is a plastic or spring one, so that the doctor will know what puncture needle to use. So of course, other specifications will be indicated here, like the puncture needle size and etc. So introducer is packed in cartons and boxes for, of course, easy shipment handling. And in the boxes here, you'll be able to see very standard blister pouch. So the outer surface of this pouch, right, it's not sterile. What is sterile is what's within the pouch itself. So this packaging comes in a tray. This tray is also sterile, but sometimes it just comes in loose accessories. So what happens is they will open the device, open the package, open the blister pouch, and they will just empty the contents onto the trolley or onto the sterile part of the bed. That's what the circulating nurse will do, right? We don't just put this, if the doctor asks for introducer kit, we don't just take this blister pouch and put it on the sterile area. We will never do that. We always pass it to someone. It's safer that way. Okay, so sterility maintenance is very important. This one, I guess you would be very familiar with this already. So again, in this introducer steps, I can tell you that there are two missing steps in the safe use of introducer sheath from these steps. Which steps are missing? So are we missing a sterilizing part, sterilizing step or priming step? Or did we not cut the skin, before introducing, or do we not puncture the skin with needle? What step is missing from this simplified image? This is actually not wrong, it's just very, 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 very simplified. Okay, so most of us got it right. So again, priming is very important, not so much of sterilizing. Sterilizing is done on the manufacturer side. So in the blister pouch, sterilized device is already sterilized, in the factory. That's why it's in the blister pouch, it's sterile. What you need to do is, what the doctor or the medical staff need to do is to prime the device, right? We need to wet the device. We need to make sure that a blood clot will not happen on the device. So priming is necessary. And cutting skin with a scalpel, sometimes they do it, but that's before they puncture skin with a needle. Typically, the most common step that they need to do before they introduce the introducer sheath is to puncture skin with a needle, so that they can put a mini guide wire and then they can put the introducer sheath through. Okay, so the correct steps are, of course, you need to first prepare the device. You need to prime the device, and then you puncture the skin with a needle. After assembly, you insert the introducer into the skin, and then remove your guide wire, mini guide wire, and your dilator, and then you are ready for your next steps. So how you prime, basically, with a syringe, saline heparin solution within it, attach it to the side tube, and prime to the device. This one you also learn during your experience during your hands-on simulation itself. For diagnostic guide wire, typically what we also call diagnostic, let me just minimize this. diagnostic guide wire, what we also call it is the 035 guide wire, 035 wire, angiographic guide wire, angio wire. There are a lot of names. Yeah, and one of the I like to call it 035 wire, so I always use this term. So what it does is to introduce angiographic or treatment guiding catheter into the vessel. So you see that you can see here, actually there's a thicker one that's coming through. The thicker device is actually your guiding catheter. They will always, again, they will lead any kind of guiding catheters with your guide wire, and that's the intention of your guide wire, to make sure that your guiding catheter curve doesn't damage your vessel. So diagnostic guide wire is basically designed to have three main structures. The core, which is made up of a kind of metal, and there's a body, which is a plastic jacket or metal coil or spring, and also a kind of coating. It can be hydrophilic or hydrophobic. There's a lot of device property that you can learn, and there's always a give and take situation when you choose these materials and options. So for example, if you choose stainless steel, it gives you very, very good strength, right? It's a very strong metal. But actually, nickel titanium, also known as nitinol, it gives better flexibility and durability. So all kind of variations actually brings out different features of diagnostic guide wire, and so there's actually a variety of guide wire that you can see out there. But this is basically the main structure that you will see. Key specifications, definitely size, usually 035. Very uncommonly that you see in PCI for IC for CAD, you will see other sizes. But so 035, typically also 150 cm. You will see the length from the tip that is flexible, the shape, and any kind of precaution. So one precaution is, for example, here they ask the operator to not use this guide wire with a metal entry needle, which means that this is a plastic one. This has a plastic cover. If you use a plastic cover, you can see with a metal needle here, it will scrape off it will not 100%, but it can scrape off the coating of the guide wire. And remember, actually, this needle is within the vessel. So this scraping off happens within the artery, within your vessel, and it may cause a lot of issues. So that's why there's some precautions that will also be indicated. So again, the carton box and blister pouch of the diagnostic guide wire packaging, not sterile. All this, not sterile. So circulating nurse will open the blister pouch without touching the content and empty this content on the trolley for the operator to use. The content in the blister pouch for the diagnostic guide wire is usually, you see this guide wire, it's in a holder tube. And one end of the holder tube, you may find this guide wire inserter. So this is a detachable part which helps the operator insert the guide wire into your introducer sheath valve. So you know the valve is quite tight so that the blood cannot flow out. This is quite soft, so it's very difficult for you to push it through the valve. So what happens is you actually insert this detachable part into the valve. You put your guide wire in, and then you pull your detachable part out again. So this is basically just to insert your guide wire into your valve of the introducer sheath. So device priming wise, usually done from the hub attached to the holder tube before the diagnostic guide wire is removed from the holder tube. So for new devices, this is what usually they do. They will usually put this syringe with the saline and heparin, attach it to the holder tube, flush it so that the water will go around and wet the whole device. Okay, so that's for diagnostic guide wire. For angiographic guiding catheter, basically function very, very simple, is to facilitate injection of contrast media. Angiographic guiding catheter can be known as diagnostic catheter or an angio catheter. So diagnostic catheter generally looks like that. It has a transparent hub that allows for contrast injection and priming. King resistant protector that is at the weakest point of the catheter, attaching the hub to the shaft. And the shaft is basically a hollow tube again, and the tip is basically it's made of very soft material compared to the rest of the shaft, because this is where you want to engage your ostium, your opening of the coronary artery. You don't want it to be hard to scrape and damage the artery, so it's generally soft. The shaft is usually has 3 layers. It has the inner and outer layer that is made of very smooth material to ensure that the contact with your vessel and also your devices are very smooth. And the middle layer is where it gives the strength. So it's usually a metal braiding, a mesh, that gives the whole shaft its strength. And again, the guiding catheter or diagnostic catheter is never straight. It always has some curve, and typically there's a primary curve and also a secondary curve. Sometimes there's also a third curve, a tertiary curve. So all this really helps to engage the catheter to the tip of the coronary artery. So the curves or the shapes have names. So the most conventional ones are the Jacquins and the Amplats. Ikari and Tiger are used. These are very modern curves. They are used more for the radial approach. So radial and femoral, that's one of the differences. So sometimes the shapes that is used is a bit different. This is a multi-purpose one, and there's also a pigtail one. It's not so much used by interventional cardiologists to put into your coronary artery. As you can see, this is not so much for your artery, but this is actually to assess the left ventricle, to monitor your LV conditions. Okay, so here you can see how the shapes are very important. So primary curve helps to point your tip to your opening, and your secondary curve help to actually provide a backup support. So it actually leans against this so that whenever you for example, you inject your contrast agent, this device will not come out. So so primary and secondary curve are important for this function. So the curves are actually all designed a bit different, and they have all different functions. So for example, Jacquins, doctors like to use it very, very commonly, but there are disadvantages. For example, Jacquins, right, you see that this is very easy to engage. It's very easy to actually point this to the ostium, but you realize that the tip is actually pointing upwards. They don't like it so much, so they want to have like the tip pointing towards your coronary artery, right? But this shape, the difficulty is in the engagement. It's very hard to get the tip into the coronary artery, but once it's in, it actually has very good alignment with your coronary artery. So that's why there's actually different kind of shapes. It really depends on the preference of the doctor and also the purpose. So for key specifications of the diagnostic catheter, basically its shape, its catheter size. Usually we use 4 French for diagnostic, and length, which is about 100 cm. We also need to know the compatible guide wire, which you'll definitely see on the label. You need to check the OD. Again, OD goes, your guide wire goes into your guiding catheter. So OD of guide wire is compatible with the inner diameter of your diagnostic catheter. Pressure limit you need to know, because you need to inject your contrast agent. And some devices have side holes, because some ostium may be quite tight. So you can imagine if this coronary artery is blocked, the opening is blocked by your tip of your guiding catheter, what happens is then you block the whole vessel and there's no blood flow. So what happens is there's some of the device have side holes here, so that blood can flow through here into your through your catheter into your coronary artery. So during the procedure, you will still have blood flow throughout the throughout the procedure. So but this one also depends on the patient's condition. So usually the opening of the ostium is a bit bigger than your tip of your guiding catheter, so you don't need this. Again, the boxes and blister pouch of the diagnostic catheter package, non-sterile. The contents, which are the paper and the catheter itself, are sterile. And this paper support basically keeps the catheter straight because we don't want it to kink, we don't want it to bend and kink, and also to maintain this tip shape. So that's why it's actually there's this support. So this support is found, paper support and the catheter are found in the blister pouch and are sterile. But one thing to note, I guess for to the CAD lab stuff is that, you know, you still have to be careful lah. Although there's actually this paper backing, it's not a solid one, so you need to be careful how you handle it, how you take it out, remove it from the paper backing also. So priming of the diagnostic catheter is done through the hub before the procedure. I think this one you saw it a lot during the procedure just now. The second operator is always doing this. He's always priming the lumen, priming the inner tube of the guiding catheter, of the diagnostic catheter, to remove any kind of, to wet it and remove air bubbles within it. So for a treatment guiding catheter, as I mentioned, this is actually very different from a diagnostic catheter. The structure is the same, but the intention is different. So the intention of this treatment guiding catheter, or also known as guiding catheter, a guide or PCI guiding catheter. Basically, the most important thing is to deliver and guide treatment catheter. It needs to be able to provide backup support for the advancement of this catheter. As I mentioned, sometimes if this is too tight, what happens is disengagement may happen. Once this happens, you can imagine you cannot ever push any treatment device with your guiding catheter looking like that. It needs to be staying here so that the device can move in nicely. Otherwise, there's not enough backup force, backup support to actually push the device through. This one not so much, but also to monitor pressure and facilitate injection of contrast media. So as I mentioned, actually, diagnostic guiding catheter and a guiding catheter, the functions are very different, but the structure is the same, right? You know that the length is the same, but of course, as I mentioned, stiffness is different, the purpose is different. So stiffness is different, and this is typically provided by the wire braiding. This wire braiding is much stiffer, and the materials are chosen differently so that the guiding catheter is given much more support. Another difference from the diagnostic catheter is that guiding catheters have different shapes. So as I mentioned, for treatment guiding catheters, you need very strong backup support. So there's a variety of catheter shapes that allows for these functions. This is for the left and for the right coronary artery. So I think key specifications quite standard. The shape itself, catheter size, it's bigger. As I mentioned previously, the treatment devices are going to be inserted through the guiding catheter. So catheter size is typically bigger. Lumen size is definitely bigger also. Length, same, 100 cm. Pressure limit is not so important because we are not focused so much on the contrast in media injection. It's about 700 psi. It may have some side holes also. So this is an interesting question. If you think about it, if I say that guiding catheter is inserted through the introducer sheath has a valve, right? But the guiding catheter has an open hub at the end. So blood will keep flowing out continuously from this hub of the guiding catheter. How do you think the blood loss is prevented? So I didn't give you an answer, but you can make a guess. Which one of the options here do you think actually prevents the blood loss when a guiding catheter is inserted? Okay, so most of us most of us thinks that the answer is to attach an additional valve device to the guiding catheter, and actually that's the way to do this. So as I mentioned, like a guiding catheter here, you can see it's open, right? So what happens is they will attach this valve device. So this valve basically helps to stop the blood flow throughout the procedure. The procedure will go on for some time, like 1 hour for PCI at least, and for CAG also. So CAG about 30 minutes. So what happens is they'll attach this valve device, and for CAG, actually for all the procedures, this side arm will be attached to a manifold that has a lot of attachment, like for your cell line, for your contrast media, pressure monitoring. This can be attached there. While here allows for all kinds of devices to be placed into. So actually, this is not opening. It's not that I close here just to open here. This is actually attached to something that is also closed. The valve is closed. So blood is actually not going to be continuously flowing out throughout the procedure. There will be this device that actually stops it. This is actually called a Y connector. So as you can see here, there's a valve here that allows other devices to be placed through. Although of course these devices, they'll be opening, right? But maybe the blood flow will be much slower because the device is much smaller, or it will not stay there for very long. Catheters are typically, this one, are typically there almost throughout the procedure or half the procedure. So you don't want the blood to be flowing out throughout the procedure, right? So you will be using this additional valve to prevent blood loss throughout the procedure. And this is the actual setup. Like as I mentioned, there's going to be a manifold attached to the side tube, and then this is a Y connector, so any kind of device, your wires and stuff can go in through here. Okay, so I'm conscious of time. Let me just very quickly run through all the devices. So the next product category is the target lesion access. From its name, you know that this is more specific to the lesion site. Sometimes it's known as a treatment device also lah. But not so much. These devices have to reach and cross the lesion that operators needs to treat. Then these products will allow for treatment catheters to then come in. Right? Sometimes typically balloons can be a treatment device, but for some lesions, it's difficult even to assess a stent through the lesion itself. So they use a balloon to open the vessel to allow stent access, and that's why sometimes balloon is also considered as a target lesion access product. So coronary guide wire is definitely in. Balloons, microcatheter, and aspiration catheters are sometimes under this product category, but of course balloon and aspiration catheter can be considered a treatment product also. For coronary guide wire, it's also known as the 014 guide wire. As you know, this is my preferred way of calling it. The difference between diagnostic and treatment, 035 versus 014. It helps to introduce device to the lesion site, and of course this coronary guide wire, it needs to be able to reach the vessel, it needs to assess, it needs to cross the lesion, and then it needs to support the device. It's made of 3 main components: the central core that tapers down, this core that tapers down distally, and it has a flexible tip which includes the coil or a plastic jacket, and it has the external surface or coating, hydrofoil. So actually very similar to what you see at 035 guide wire. But this has more functions again. So its design is a bit different also. It has this core diameter that's very important. That's typically 014, as we mentioned. Yeah. So the length of the wire is called a shaft, and yeah. Basically the size again is 014. There's rarely any other sizes that is used for CAD. Commonly used 180 cm, and radio opaque length, which means this part can be seen under the under Fluoro. So not the whole entire device can be seen very clearly under angio. Typically there's this at the tip, you will see like 3 cm of the radio opaque, and you will know that this is the guide wire within the coronary artery. There's different kind of flexibility. As I mentioned, this is a bit more complex than your 035 wire. You need to cross your lesion, right? You need to support device. So there's different kind of coronary guide wires that can be used in the procedure. It's not just one that is used in the procedure. There's of course a workhorse, but typically they, especially in a very complex case, they will actually switch out the different kind of guide wires. And also take note that a guide wires can be extended typically at the end of the guide wire. See, this says that it's extendable. It says it's extendable. It means that the tip will have a certain shape. This one is a straight type, so it needs to be compatible with a extension wire that is a wave type, so that it can be attached well and used together. So here you can see basically they are attaching this guide wire with the extension so that it can be a very, very long guide wire. So yeah, this is one thing to note about extension wire. It can be extended. So they're attaching it. So we typically don't cross brand for this because it may not attach well since you know that the types actually differs. So we need to be very careful about which extension wire we use. So for the package wise, the carton box and blister pouch, again, not sterile. These are always not sterile. The content of this blister pouch is sterile and it usually contains the holder tube with wire. Here a bit hard to see the wire. The wire is here. And there's typically this shaper that comes with it. As I mentioned, guide wire for 014 is actually different for 035. For 014, because your lesion is always slightly different, your angles, your coronary arteries is a bit more complex. Typically what an operator do is he actually can shape the tip. That's why the tip is actually flexible and shapeable. So they will either use this shaper, they can use their hand or insertion sheath even, not insertion sheath, puncture needle, insertion device to actually shape this this wire tip. So preparation of this guide wire, I think it's a bit more complex because as you can see from this image, there are a lot of attachments here. But the holder hub is where you actually, I think as with other devices, is where you actually inject your saline with heparin to wet the device. So what you will see here is when you actually push, this is the out here, this is the wire rear end, which is the end tip. This is the stiffer part. So when you push it through here, you need to actually remove the guide wire because actually it's 014. It's a bit like your hair diameter, right? So it's so fine that you need to make sure that it doesn't move in the package. So there's actually this clip here. So we need to remove this clip. And when you push the wire rear end here, the wire will come out from here, the holder hub. Yeah, so basically that's the that's how the wire work. Like the soft part always comes out from here. The wire rear end is here, so you just have to remove the wire clip to push the wire rear end to reveal the wire itself. And this is the coronary guide wire setup. As I mentioned, for your guiding catheter, your Y connector will be connected to it, and your guide wire, like a hair, it has to go into the Y connector. And how does it go into? Like a 035 guide wire, it needs an insertion. It doesn't come with the holder itself. It's actually this something called an inserter. So there's actually an inserter that looks like a needle that you can actually put your wire through, and into your Y connector, put your hair, put your 014 wire through this inserter and the Y connector, and then remove the inserter. So typically that's how guide wire is actually inserted through the device, through the setup. And also we have something called the talker. A talker, as I mentioned, your 014 wire is so fine, right, that sometimes it's very hard to manipulate. You need to actually rotate it and advance it through the lesion. Sometimes it's really difficult. So you have this device that you can attach to your guide wire to actually rotate and advance, help to basically move the device through. Okay. So I have only 10 minutes. Let me try and finish this. Balloon is actually one of the more important device in PCI. Basically, it's used to dilate the stenotic region. Basically, initially it's used as a POBA. So it's called a plain O balloon angioplasty. Like what I mentioned previously, it's used for dissection, it's used for compression, it's used for stretching of the lesion. But we realized that to allow for blood flow again. However, in recent years, we realized that after you balloon it, it somehow the lesion will return, because even if you compress it like fats, if you compress it after a while, it actually come back to its original volume. So your vessel become thinner again. So POBA, plain old balloon angioplasty, does not actually work very well. So typically what balloon is used now for is pre-dilatation and post-dilatation. So pre-dilatation means that if there's a vessel here and your lesion is this way, it's so tight. You can see that the access here is so tight that you can put a guide wire through, and that's basically it. Even you cannot, if you try and put a stent in here, it's hard to push it through. So what typically doctors will do is to pre-dilate. So they will put in a balloon catheter and try to expand the balloon so that this lesion will be compressed a bit. And I don't need it to be compressed for a very long time. I just need it compressed a little. Then I can use a bigger balloon and compress it even more, and then put in my stent, keep it at that size. And then after I keep it at that size, sometimes I'll do post-dilatation. Basically, use a very hard balloon to press this stent against the vascular wall after I deploy my stent, to make sure that my vessel stays very nicely open. Right? I don't want it to actually collapse it down, so I use a harder balloon to actually do post-dilatation. So that's how balloons are usually used recently. And for the structure, basically it will have two lumens in the shaft, one basically for the balloon to be expanded, and one for the guide wire. So other devices usually has one lumen. Balloon catheters have two. They have one for the guide wire and one for the balloon. So proximal markers can be found. This is to make sure that the operator will know when approximately, this is usually at 90 cm and 100 cm. So you know that guiding catheter is usually 100 cm. So at 90 cm, the operator can go in very fast. From 0 to 90, they just go in very fast because it's in the guiding catheter, it's fine. But once it's going to exit the guiding catheter, it means that it's going into the coronary artery. They have to be careful. So these markers basically help them to identify when to slow down, when to take care of my fluoro. Now I need to turn on my fluoro to find my balloon device. On my balloon, I will be able to see, basically this is shaft, and at the end you can see the balloon itself. The balloon will have these markers, which you will be able to see under your angiogram, under your fluoroscopy. So under fluoroscopy, you can see these two markers moving, and that helps in your positioning also. Okay, so balloon is quite straightforward actually. For catheter types, as I mentioned, there's two lumens, one for the wire and one for the balloon. If these two lumens are actually within the top itself, it's actually called over the wire. The wire and the balloon lumen is coming from the same opening. But typically what happens is we have a RX, rapid exchange catheter. So for balloon catheter, RX is actually commonly used. This is called rapid exchange. Rapid exchange meaning that you can see here, there's actually a dent here. The wire will come out from here. The balloon will go in. The balloon lumen is actually here. It will be expanded through here. It's a bit difficult to explain here. When you touch your device, you'll be able to appreciate it even more. Just note that most balloon catheters are rapid exchange. You rarely see a over the wire balloon catheter. Of course, the diameter and length will be stated. Again, there will be radio opaque markers. Sometimes there's one, sometimes there's two, so you'll be able to see it shaded on the box. Working length typically longer than your guiding catheter. It has to go to your lesion, right? So more than 100 cm is typically 145 cm. shaft diameter, you need to know this to be able to check compatibility. You need to be able to make sure that this catheter can fit into your guiding catheter. So again, for rapid exchange especially, you have your guide wire and your balloon shaft in the same space, right? So you need to make sure that there's actually enough space. As I mentioned, typically not one device is used. Sometimes actually two balloon devices are placed into a guiding catheter, and this means that you need a lot of space. So you need to actually calculate the inner lumen of your catheter and match it to your balloon very carefully to make sure that things doesn't get stuck in the procedure. Of course, coronary guide wire needs to be compatible. Typically, 014 wires are used. This is quite an important concept. NP and RBP. NP stands for nominal pressure. So nominal pressure means that at this pressure, at this ATM, the catheter will be, the balloon will be expanded to its indicated size. So you can see that the NP for this balloon here is 12 atmospheric pressure, ATM. So at 12 ATM, your diameter is actually 3 mm. And this balloon is a 3 mm balloon. So nominal pressure basically tells you how much pressure to actually inflate the balloon to its indicated size. But most cases, we cannot actually have like balloons for 3.1, 3.2, 3.3. So what happens is this balloon, there's some flexibility in the balloon. So there's actually something called the rated burst pressure. You can keep going up, you can actually keep increasing the pressure so that the diameter increase, but there's a point where the balloon is going to burst. And that's where the doctors will not go up to, right? So RBP is the maximum pressure that the doctor can go up to. So this RBP, for example, is 22 atmospheric pressure, ATM, 22 ATM. At 22 ATM, the diameter size is about 3.2 mm. So for example, if the doctor sees that I want to actually expand my lesion to 3.15, so I take a 3O balloon and I expand it up to 20 ATM and I get 3.15, then I'm happy with this balloon. I can use this balloon for that. But I cannot say that it was a 3.30 balloon. For this balloon, I want to go up to 3.25. It goes beyond my rated burst pressure for this balloon. So if I go beyond this, there's a very high chance that it will burst. So doctors will typically not do that. They will go up to the RBP. So NP is you can say the minimum pressure that you will use on the balloon, RBP maximum. Okay, so SC versus NC. So what is SC balloon? Semi-compliant balloon is basically softer balloon. So just now, as I mentioned, the function of balloons nowadays, pre-dilatation. Pre-dilatation means that I need to actually put this very small balloon, very soft balloon, into a very, very tight lesion. Usually softer balloons can go into such spaces. So this kind of soft balloons typically very easy to expand. At low atmosphere pressure, it can go up to its indicated size, and it's very easy to burst. At a very low RBP, it will burst. If you go beyond like 16 ATM, it will burst. But for NC balloon, these are very hard balloons. So these are harder balloons, so it can be used to, for example, it can be used for dissection. It can be used to open the stent post dilatation. After you actually deploy the stent, you want to make sure that the stent stays open very well. I will use a very hard balloon called NC balloon. NC balloon, very hard, right? So it's very hard to expand it. At 12 ATM, you can then hit the indicated size, and it's also very hard to burst. So it needs a higher pressure for it to burst. Okay, so basically this is about NP and MP and the different kind of balloon: a soft balloon, semi-compliant, and a hard balloon, a non-compliant balloon. So balloon size, as I mentioned, that's how you check between your NP and RBP. You can see what kind of pressure actually relates to what kind of sizes. Actually, I'm conscious of the time. I know that we are running out of time. Is it okay if we go on, or how do we want to do this? Is it okay if we go on?
Yes, you can go on, Sinchi, until finish.
Okay. I'm sorry
The
about the
doctor
noise.
the professor allow us.
Thank you. I'll try to go fast, but still, I want to cover everything also. So, yeah, just give me. I'll try to speed up. But I also don't want to miss anything. So, let's move on. So, in this question, basically, you know that PCI procedures, NC balloon, the hard balloon, and a soft balloon, a SC balloon, are used for different purpose. How would the doctor know that this balloon catheter has an NC or SC balloon? You know what I mean? So on the label itself, how do I know that it's actually a soft balloon or a hard balloon? Okay, so yes, actually NP and RBP is actually the greatest indicator on whether this balloon is soft or hard. As if you see from the previous slide, you know that soft balloons, low NP, low RBP. A hard balloon, NC balloon, has a higher NP and RBP. So that's how you know that actually which one is a semi-compliant, which one is a non-compliant. Sometimes actually even in product names you can tell, but it's not 100%. Okay, it's not 100% that the product name will say that this is a NC balloon or SC balloon. Typically, a more accurate indicator is your NP or RBP. The box and blister pouch, again, non-sterile. Within this blister pouch, you can find two items, which is your compliance chart. Your compliance chart is where you find your NP, RBPs, and your balloon diameters, right? Just now we saw this on the label also. This is actually included in the package also. You also see your device, and this device, you will see a small device that is attached to it. It's a flushing needle, and this comes with a rapid exchange balloon catheter. You will also see another device that may come in with the compliance chart, and this is the rewrapping tool. So as I mentioned, devices may not be used once. Devices can be repeatedly used, sometimes to save cost. So sometimes if I want to treat more than one vessel, I can put in this balloon, leave it aside in my tray of saline with heparin. I soak it in there, and then for my next vessel, I want to use it again. So I take it out and then use it again. But once you open the balloon, it gets bigger. So I want to keep it small so that I can actually insert it into the next lesion. So what I will do is actually use a rewrapping tool to make the profile of my balloon smaller. So maybe you get to experience this also, but this is one interesting thing that is provided that helps the doctor reuse device. So preparation of this rapid exchange balloon catheter, as I mentioned, for rapid exchange, for balloon catheters, there are two lumens, the wire lumen and the balloon lumen. So for the wire lumen, you can actually prime it or prepare it by inserting this flushing needle. It's quite small flushing needle into the tip, the end tip of the catheter. So because when you actually insert it in here and flush it through, what happens is the wire lumen here, the wire exits here, right? It will be flushed in this way. So within here, this is actually not primed because the balloon lumen is actually not exposed to the air. The balloon lumen basically helps to expand the balloon to its size. So they also remove air, but not, the purpose is actually not to prevent the insertion of air bubbles into the vessel. This priming or preparation is actually so that there is no air in the balloon itself, because if there's air inside, sometimes you can't see the expansion under your fluoro very clearly, under your fluoroscopy very clearly. So they don't want this to happen. So what they do is to pull air out from the balloon by negative pressure, and then I will insert I will drop one liquid to actually seal it. So it's actually a negative pressure. I'm making it vacuum. I'm making the inside vacuum. So this one you'll definitely be able to experience it. You will be able to see how this negative pressure is done, so that this, when you fill in your balloon, it will be completely filled without air bubbles. Okay, so for balloon catheter setup for rapid exchange, you will see it like that. Basically, you remember you put your 014 wire in first, and then your treatment device. So your treatment device will go in through your 014 wire, and when you put in through, you'll see your 014 wire still, because it's a rapid exchange system. And when the guiding catheter when this treatment catheter goes through, balloon catheter may come out of your guiding catheter, as it's a treatment catheter, right? So your balloon catheter will be extending from your guiding catheter. Again, this is a bit hard to visualize like that, but once you see the actual vessel model, you'll be able to appreciate it more. And one thing to note is how you expand the balloon here. There's this device called the indeflator. And indeflator is basically a device that it can be basically attached to, just now I say this is the balloon lumen. So you attach it here, and then you basically increase the pressure. So you see this gauge. When this gauge goes up to like 12 atm, 20 atm, you will then be able to know how much the balloon has expanded. So indeflator is used to expand the balloon. Okay, so that's for the balloon. The next target lesion assess product that I'm going to introduce is the microcatheter. So as its name suggests, it's a smaller version of a guiding catheter. It can be called a micro guide catheter or support catheter. So there's a very specific use of this microcatheter. So here you can see a very tight lesion, guide wire wants to go through. You keep pushing, as I mentioned, guide wire sometimes very hard, like, it's so small. So even the guiding catheter cannot provide enough support to push this guide wire through. So what happens is you can actually put this microcatheter up to very close to this lesion site, so that this guide wire will have enough support to be actually to track and pass through the lesion. Another function of this microcatheter, once your guide wire is here, let's say that I use a very hard guide wire here. A very hard meaning that I may actually just poke through my vessel, damage my vessel. So I want to change it to a softer one to make it more safe, to make my procedure safer. So I can, once my guide wire goes through, I push my microcatheter here. I exchange the hard guide wire, the stiff guide wire, to a soft guide wire. So this is another function of a microcatheter, to facilitate this exchange of a guide wire. And this is not so much for IC. We can inject radio opaque contrast media through microcatheters, but for IC, these two are actually the key functions, basically to support guide wire in crossing and also to facilitate the exchange of a guide wire. A microcatheter looks exactly like any other catheters, your diagnostic catheter and your treatment catheter. So yeah, I think I don't need to elaborate on this. Key specifications, there's always going to be the catheter size, because you realize that this catheter has to go inside your guiding catheter. So it's very important to look at the outer diameter of this catheter to see the compatibility with your other devices. Effective length, longer than your guiding catheters, your diagnostic catheter, which is 100 cm. This is 150 because it needs to extend further than your guiding catheter into your coronary artery. This is, again, typically compatible with 014 guide wire. Radio opaque marker, as I mentioned, most devices will have a radio opaque marker, because under Fluoro, I want to know where my devices are very clearly. So there's a point where there's a part of this device where it's much clearer under Fluoro for the safety of the patient. Catheter type, typically over the wire. So packaging of this microcatheter, nothing different. It comes in a box, blister pouch that are not sterile. The only sterile thing is the holder tube, which contains the microcatheter. Preparation of this catheter. Again, attach this to the holder tube to flush if it's a hydrophilic, and we can also attach it to the hub to actually flush the insides to make sure that there is no air introduced into your vessel. Okay, aspiration catheter, as I mentioned just now, this is important for you to know as a treatment device. Basically, it's a primary, it's used for PCI as a treatment. So you can see that at the red spot, after the red spot, there's a clot. So no blood can flow through. So thrombectomy aspiration catheter basically is interestingly shaped. So there's kind of like a scoop. So it's used like any other treatment device. Once the 014 wire goes through, you push the aspiration catheter through the blood clot. And when you pull back, you will actually suck the blood clot up. So with this vacuum syringe, you actually pull back so that the blood clot is actually removed from the site so that blood can flow again. So initially, if you look at this, it's actually very exciting, right? It's this in 2000s, this is early 2000, it was very exciting. People think that this is very revolutionary and it will change the practice. But then there's actually very disappointing results for coming from large-scale trials on this concept. So it lost its initial appeal, but it's still used to actually remove blood clots in some cases. Yeah. So for aspiration catheter, it looks like any other catheters, except that it looks interesting because of this scoop. Basically, it has a lumen for aspiration and a wire lumen. This wire lumen, like what you see for rapid exchange, it has this wire lumen very clearly here. You can see it's coming out from here. So it's a rapid exchange system. The lumen for aspiration, a bit like balloon, but here you attach the syringe that cause a negative pressure. So when you do negative pressure, you actually suck the blood clot through this shaft into the syringe. So key specifications, I won't elaborate. Catheter size, check compatibility, effective length longer than a guiding catheter, about 140 cm. Rapid exchange, it really depends on this is your wire length, where your wire is. Tip specifications, this one usually differs a bit different between companies. How deep is the scoop? Compatibility, of course, check. Stylet is something that is used because it's generally quite soft. So stylet is actually included within the device so that it can actually support the device to push through the blood clot. So packaging wise, box, blister pouch, not sterile. Within it, with the paper backing, it is sterile. So it has a few devices here. So that comes with the aspiration catheter itself. This is usually preloaded with a stylet in the holder tube. It has this vacuum pressure syringe also. This vacuum syringe is basically to pull, you'll be able to pull back so that you can actually suck up the blood clot. And you have this filter cap, basically is, once you suck out the blood clot, basically you empty the content of the syringe into this filter cap and you can observe the blood clot. So let's take a look at the preparation and use of this device. So what they're doing now is actually the priming of the device. So they are priming first the outer surface of the catheter. After they remove the catheter from the holder tube, they will now prime the stylet, the catheter, like the insides of the catheter. Now this is how they create the vacuum. They pull back empty air, right? They pull back, that causes a negative pressure. Now they will backload the guide wire into the catheter and then load it into the guiding catheter. So you can observe here how a rapid exchange system works. So you will be able to see the guide wire extending out from the guiding catheter and push the device through. So now they will remove the stylet. This stylet basically again helps to push the device through. Now they attach the vacuum syringe. And once they open the syringe, and they pull back, they'll be able to suck back on the blood clot. Once they're done, they can close it and then empty the content. So that's how the device is removed from the catheter. Yeah, so that's how the filter is used, basically to capture any kind of blood clots, and you'll be able to observe it under on the. Then they reattach the stylet, and that's it. Okay, so aspiration catheter is very interesting to observe. So I don't know whether you'll be able to see it, but maybe during the hands-on, I think if you have time, because as I mentioned, this is not very commonly used now, so it is not our priority normally when we do demonstration, but it's actually very interesting to observe. Okay, let me move on. There's 2 more categories only. I have 3 more, but very short ones. So the therapeutic part, product category, I think you are very familiar with stent, as I mentioned a bit previously, but I will also cover a little bit about drug-eluting balloon. So basically, a coronary stent system is just called a stent. Typically, it's used to support the coronary artery. And the coronary stent system must first be able to, of course, deliver the stent to a lesion site here. It must first go in, and it must fit the vessel requirement. How wide is the vessel? And it must not cause negative clinical outcomes over time. So it has to stay in the patient's body forever. So coronary stent system, the general structure, very similar to a balloon structure, even for in terms of rapid exchange, etc. It's very similar. The only difference is that it has this stent that is crimped at the distal edge of the system, of the shaft. So the stent itself, it has it can be a bare metal, which means that it's just purely metal. But typically, recently, what is commonly used is drug-eluting stent, which means that there is this polymer that carries drugs on the stent, that is attached on the stent, so that when it's delivered to the vessel, this drug will be released to the vessel, so that there is no injury caused. The vessel will recognize that because of this drug, they will realize that we don't need to create new tissues and new layers, which will actually, because initially what happens is when we use a bare metal stent, there's vessel injury. Your body realize that this is a foreign material, then they will grow additional tissues around the area, and it causes more blockage in the area. So that's what happens in the previous stent designs when there is actually no drug. So this drug is to let the body realize that this is actually you don't need to grow new tissues here. So once the stent keeps it open, the vessel will be kept open, the lumen will be kept big throughout the patient's life. Okay, again, catheter type, rapid exchange, stent diameter will be indicated along with the stent length. It's very similar to balloons, right? So working length, 145 cm. Shaft diameter, again, we need to check, because all this compatibility we need to check, because they are used in sync with each other. So we need to make sure that they are compatible with each other. Again, NP and RP is very important because it will help to actually size the stent also. So for example, this stent is a 3 mm diameter stent. So if I go up to nominal pressure of 9, I will be able to go up to 3 mm diameter. But I can expand the stent further. I can go up to even 3.2 by increasing up to my RBP of 16 ATM. But I shouldn't go up to 18 ATM. Even if I want to go to 3.25, I should use another stent, for example. I shouldn't actually go up to 3.25 because there's a risk that the balloon may burst within the vessel. For the packaging of a drug-eluting stent, it's actually quite unique because there's actually drug on the stent itself, right? So this drug it must be compatible with the patient's body. So it's actually quite sensitive to heat and light. So typically this device is actually packed in an aluminum pouch, and actually it's quite straightforward again. Nothing here, even this blister pouch in the aluminum pouch is also not sterile. What is sterile is the holder tube and the compliance chart. Since it's a RX device, it has this flushing needle so that you can flush the wire lumen. So it's the same as a balloon catheter preparation, so you can refer to that material if you need. It's here. So just a very short history again about our treatment procedures. So you know that initially balloon was used, and I mentioned how balloon is not very effective because the lesion doesn't stay open for very long. The patient will come back again saying that they have a heart pain and they need to actually do another procedure. So subsequently, you realize that a structure is required to be placed at the lesion site to keep this vessel open. So for a few years, bare metal stent, just a metal structure inside is used. But you realize that the body will eventually form a layer of new tissues around the vessel, and because of this new tissue the vessel size becomes smaller again, so it's not very effective. So drug-eluting stents is then introduced. Drug-eluting stents meaning that the drug will let the vessel know that there's no need to actually create new tissues here, so the vessel lumen size will be maintained. But people still try to improve. They think that they don't want to have any kind of foreign device in your body for a long period of time. So so they want to combine the effect of this drug and balloons. So that's how the drug-eluting balloon comes about. Basically, it's a very conventional SC balloon, semi-compliant balloon. It's covered with drugs to be released into the vessel wall. So drug-eluting balloon is a very new concept, and there's a lot of challenge around it. So again, this drug is to tell the vessel that you don't need to actually build this tissue. You don't need to scar. You don't need to build new tissue. So I open it, and then you don't, as long as you can maintain it like that. However, there's actually a lot of difficulties, even in the delivery. This drugs is actually just on the surface of the balloon. So when you deliver it on the way, you may actually lose a lot of the drug. So that's one issue. Another issue is actually once you actually get to the vessel site, the drug actually is introduced to the lesion. It may be washed off very fast. So actually there's a lot of issues, and the effectiveness is not very high, but it's still used in certain conditions that is very tricky. So certain like small vessels where you cannot put your stent in, for example, they might use this balloon technique to try and resolve the problem. But it's usually not the first device that they will take out for solutions. This is usually if I got no other options, if there's very tricky conditions, then I may actually use this drug-eluting balloon. But otherwise, it's actually really not commonly used. Okay, so last two product categories. This is about closure. So one thing to know about closure is that it's very specific to radial and femoral access. I think you saw just now, and the products are very unique and Actually, knowing them will take another course, so I'll just introduce them very, very closely. So in the background, you can see this is actually a device that closes femoral artery puncture. Like it uses like a sandwich mechanism to actually close the puncture site. So this is just one mechanism of a closure. Again, for femoral access, TFI versus TRI, they use different concepts for closure. So for TFI, what you usually use as closure is called vascular closure device. And for TRI, it's called radial compression device. So as I mentioned, for conventional vascular closure, for femoral, it's typically by manual compression. So this medical staff, it could be nurse, technicians, young fellow, we have to put pressure on the femoral artery for the patients, maybe for a few hours. It could be up to 4 hours or so, depending on the patient condition, so that the blood will stop. So you can think of the negative side of manual compression, which includes the time required, the manpower, patient discomfort, since the patient will not be able to move, and many more. That's why vascular closure device is developed, and these are known as VCDs. So VCDs basically have these advantages which counter the negative side of manual compression, which I shared on the previous slide. So manual VCD can work in two ways, the passive and the active mechanism. Passive meaning that the device do not actually reduce the hemostasis time or to shorten the time to ambulation. Some examples are shown here. But for active mechanism, they actually close the puncture site actively. Basically, it makes the puncture site smaller using suture or using like, sandwich mechanism or a clip like what you saw just now. And yeah, basically this all helps to replace manual compression. And there's a lot of ways, as you can see here, there's actually a lot of ways to do it, and it's very hard to standardize and describe, so I will not be trying to do that here. For the radial side, the conventional way of doing it is using a bandage. Actually quite straightforward. Their puncture site is not very big, so they can use a bandage to just close the puncture. However, for a typical bandage, right, they just put the pressure on the whole surface area. So what one thing that is observed is that there's actually something called the radial artery occlusion. So eventually, this artery cannot be used anymore. The artery is closed up because the pressure is placed on there for so long. So what happens is that we realize that there's a need for a specific device that helps to, minimize this, that helps to stop the bleeding. It stops the bleeding but still allows for flow, and there's something called patent hemostasis. And that's what most of the radial compression device try to achieve. They try to make sure that the compression is just enough to stop the blood from flowing, but blood still can actually flow to your hands so that your hands will not be numb. Okay, so for radial compression device, there's actually different kind of mechanism. So there's one that uses a dowel, one that uses air pressure. So there's actually also different kinds. So I won't be able to elaborate too much on this. Just know that these are all the radial compression device that can be used to close the puncture site for radial access.